person I invite our next speaker, please.
Nani nani चले गए
pin. इसमें sorry for the technical glitch. Again, respected chairpersons and all the audience, I'll be beginning on the topic PKPD implications of antibiotics. In the morning, we have already shared a brief outlook with sepsis, the sepsis definition and the sepsis guidelines, and the current perspective, what all things is recommended, what is not recommended, what is the current evidence to support. So now moving forward, PKPD becomes quite an important topic to decide an appropriate dosing and further plan of antibiotics in critical care to have a better outcome and a better understanding of the disease process. Moving forward, PKPD is the relationship between the drug exposure and achieving the desired effect is referred to as pharmacokinetics oblique pharmacodynamics. The success of antimicrobial therapy is determined by the interaction between the administered drug, the host, and the infective agent. The complexity of these interactions is responsible for the difficulty in selecting an appropriate antibiotic regimen in ICU. If you look, once we prescribe an antibiotic, after giving it, there is a serum concentration, there is a different concentration at the site of infection. There will be some concentration at the non-targeted tissues. There will be therapeutic effects, there will be side effects. If you look at the pharmacokinetics and dynamic, these are the principles which are involved. So pharmacokinetics is described as what the body does to the drug from drug absorptions to drug elimination. So PK of any antibiotic will depend upon its absorption, its distribution, its metabolism, and its elimination. The absorption and bioavailability of antibiotics is determined by two important factors. One is the route of administration, either rectal, buccal, IV route. Oral route has the lowest bioavailability. Certain antibiotics, the absorption is significantly reduced by food, azithromycin, isoniazid. And some antibiotics are not absorbed entry at all, the rifaximin. If you look at this graph, this is just a comparison. If you give something IV and something oral, the concentration which is achieved, the bioavailability is almost 100% if you give IV. And if you give oral, it takes some time. And it's not always 100% bioavailability. So probably we should not be using oral antibiotics in serious infections, probably in patients with hypotension and shock. Blood is redistributed towards vital organs and away from splanchnic circulation. We must know something about the drug-food interactions when using oral antibiotics. Antibiotics with more than 90% bioavailability, we can switch quickly from IV to oral depending on the clinical improvement, especially metronidazole, clindamycin, levofloxacin. This we routinely practice in our intensive care practices where we call it as antibiotic stewardship strategy, where we can move quickly from IV to oral in case if you have a better bioavailability, as well as it is cost saving and also it reduces the chances of bloodstream infections. Distribution of a drug molecule in various body compartments mainly depends upon the molecular size, the lipid solubility, the protein binding. Based on lipid solubility, the antibiotics can be also classified as lipophilic as well as hydrophilic. If you go into the hydrophilic antimicrobials, the general PK principle says there is low volume of distribution, predominant renal clearance, low intracellular penetration, but everything gets altered in a patient who is admitted in intensive care. So there is a higher volume of distribution, either there is an increase or decrease in clearance dependent on the renal function. Similarly, the lipophilic antimicrobials, normally in general PK principles, you have high volume of distributions, predominant hepatic clearance, but same get altered in an intensive care patient. This is just an example where we look at all the hydrophilic antibiotics, especially aminoglycosides, beta-lactam, colistins, daptomycin, and lipophilics, mainly the fluoroquinolones. So if you look at the fluoroquinolones, macrolides, tetracycline, linezolid, they have good tissue penetration, large volume of distribution. Linezolid has a better lung penetration. Levofloxacin is a good antibiotic for pneumonia. Minocycline also has got a good penetration in lung, abdomen, and bone. Some of the drugs which are high protein bound are not routinely removed by dialysis, less likely to be affected by the augmented clearance, especially in sepsis trauma. less penetration into the tissue, especially the beta-lactam, aminoglycosides, daptomycin, colistin. So they have less penetration into the tissues, deep-seated infections like pneumonia, abdominal infection, probably because of the small volume of distribution. Sepsis leads to capillary leak, causing an increase in volume of distribution with subsequent drop in the available serum concentration of the drug, which is, I think, the area of interest where we are all struggling. Few beta-lactams has got high protein binding, exceptions cefazolin, ceftriaxone, ertapenem. So dosing of these drugs is unpredictable in sepsis. What I personally feel, every drug is unpredictable in sepsis. That is why we are trying to learn. The pharmacodynamics, PD is described as what the drug does to the body. Is the study of effect of drug with respect to its concentration. Pharmacodynamically, there are three major patterns of antimicrobial killing. One is time-dependent killing, concentration-dependent killing, and concentration-dependent with time-dependent mechanisms. So I think there was already a discussion related to all this mechanism where we actually want to have a chances of improve outcomes. That is where the PD principles works. If you see time dependent, the killing depends on the time for which the antibiotic concentration was more than standard. That is 4 times the MIC. The objective of this type of killing is to maximize the duration of antibiotic exposure. This can be achieved by following strategies in our intensive care practice. Either we increase the frequency of dosing, either we increase the dosing duration or extended infusion, and a loading or a higher dose. I think which we already had a significant discussion about giving meropenem 2 grams stat followed by an extended infusion. So probably that is one strategy in present consensus, which is coming up in a large way in terms of reducing the or improving the chances of sepsis improvement. So what also we routinely practice, we give 2 grams of meropenem and then continue with an infusion, 1 gram as an infusion of 4 hours. But there is a lot of recent literature which is coming up and a lot of recent papers and trials. So few of them are very much positive for extended duration of antibiotics. And the recent paper in, I think, 2023, which is there is some misleading, or the 28-day mortality remains more or less same. But considering it's our own, I have also used this infusion and a higher boluses. It practically works. And I have also seen a good chances of sepsis improvement in our clinical practice. So still research is going on. There are drugs which are concentration dependent. Killing depends on the maximum concentration achieved. The objective in this type of killing is to maximize the post-dose concentration. Killing depends on the maximum concentration of the antibiotic achieved, irrespective of the duration of exposure. There is also a post-antibiotic effect in concentration-dependent antibiotics. This can be achieved by following strategies: infrequent administration or once daily dose in a higher dose formulation. So probably we are using amikacin, but in our day-to-day practice, I have seen physicians prescribing amikacin 500 milligram BD, 500 milligram TDS. So probably if you have some idea of pharmacodynamic principles, we should make it 1 gram OD if you want to give amikacin. That is how it is going to change the outcomes. Similarly, if you are using meropenem and you are not giving in an appropriate dose, so that creates a lot of trouble in terms of overall survival, as well as we are building a lot of MDR resistance in our ICU patients, which is a major threat what we are struggling. And most of us, we are working in an open ICU environment where I personally feel the challenge is manifold. Even if I know something, it is my duty to speak to the primary consultant or speak to the physician, like this is how we should practice this. So there are difference of opinion. Probably in my clinical observation, I have recently done a survey or an observation study where my patients have not received a single dose of antibiotics second time. In emergency, they have received a dose of Monosef. In ICU, they have received a dose of Tazac. And by morning rounds, they are receiving a dose of meropenem. So that is the area we are struggling. So either we are not following any principle, or probably the consultant effect or the senior effect or difference of opinion among the primary team is a major concern rather than the PKPD itself. So that is one area where we can improve. That could be improved with your antibiogram practices, with a better interaction with the teams, better understanding with the residents, because probably the resident starts the first antibiotics and consultant decides the second dose of antibiotics. And the clinical worsening. Sometimes the clinical worsening patient also is not getting the escalated antibiotics. So that is the area where we are worried. Persistence of bactericidal or bacteriostatic activity after drug concentration achieved at the target site fall below the MIC. Organisms takes time to recover from the effect of initial high concentration of antibiotics and resume the normal growth. Aminoglycoside and fluoroquinolones have shown to have a lot of significant post-antibiotic effects. Few drugs which has got concentration as well as duration as their mechanism. Killing depends on the maximum drug exposure. So this can be achieved by administering a high total dose and frequent doses and large doses. So probably that is one group of pharmacodynamics where we are looking at. The possible antibiotics are fluoroquinolones, polymyxin B, colistin, vancomycin. Probably I think in the entire house, there could be a significant debate if I talk about the doses of colistin per se. That is the most significant problem what I have realized in my clinical practice in intensive care. Again, the challenge is manifold. How you give colistin. Some people are really worried. My kidney will be totally damaged. And at the same time, you are seeing a worsening patient. You are not loading with colistin. Probably that is also bad. So we are giving 1 MIU TDS. Somebody is giving 2 MIU TDS. Somebody is giving 12 million units loading. Somebody is giving 16 million units loading. So probably with the advent of more and more MDR infection, more and more resistance bug, and probably we are seeing, I think all of us are seeing colistin resistance, polymyxin resistance. So we don't have too much to work on. But probably in these subset where we are seeing colistin resistance, polymyxin resistance, we must think of a better alternative as a combination therapy because we don't have much antibiotics to choose from. Probably with good antimicrobial stewardship, better understanding of PKPD, because after a period of time, this colistin is not going to work if you are giving 1 MIU TDS. Some are worried, even if patient is deteriorating, you are giving only nebulization colistin. Probably it's not going to work. So if you are thinking in terms of sepsis, my patient is clinically worsening, deteriorating with flared up sepsis, probably we must do a higher doses of meropenem, higher doses of colistin. And if you feel my patient could be a possible immunocompromise, we should think of an antifungal as a first line of treatment. And probably with advent of newer molecular diagnostics, newer approach where we can de-escalate our antibiotics quickly, depending on the clinical improvement. But that also paper is very difficult to convince. I have seen patient receiving colistin for 14 days. I have seen patient receiving colistin for 6 days, 10 days, because there is a debate with the primary team. Since this patient is already improving colistin, why you want to stop a drug which is sensitive? So that is an area of challenge where we look at. So practical implications could be a higher doses of levofloxacin, ciprofloxacin. I think each one of you are trying to give a higher doses in terms of looking at a better outcome. But every time it doesn't work because we don't have the clear answer, because the lot of polypharmacy, lot of clinical decision making comes into the way where we feel a patient of dengue illness deteriorating, we don't miss on antibiotics. We give a patient of dengue positive also meropenem, we give colistin in case of worsening. We also start an empirical doxycycline antifungal because you never know that you are missing a sepsis. So that is the area where we are building up resistance. That is the area we are loading too much. And the de-escalation part is very difficult. Whatever best we speak, whatever best we see, probably I think de-escalation is very difficult in our clinical practice. Whatever book says, but in our clinical experience, I hope all of you must be agreeing, de-escalation policies are very difficult to de-escalate. But in case of clinical improvement, definitely we are able to de-escalate to a smaller group of antibiotics. This is one slide where we have a larger volume of distribution, AKI requiring CRRT. We have to have dosing solution, appropriately weight adjusted loading doses, individualized patient dosing based on the physiochemical properties, intensity of CRRT, and the native renal function. With renal compromise, we have increased total daily dose, more frequent dosing, continuous extended infusion, and therapeutic drug monitoring. I think most of the ICU does not have therapeutic drug monitoring where you can actually measure the concentration and you can modify your drug dosages. I think only AIMS is doing some work on therapeutic drug monitoring, but most of the ICU, it adds to the cost. And where to add to the cost, I think the critical care or the intensive care is already reaching to a very high level in terms of cost. This is just an example. If you look at TG cycline has a very large volume of distribution. The volume of distribution is the measure how much drug goes into the tissue. Larger the volume of distribution, the lesser will be the drug available in the circulation. TG cycline reaches virtually every body fluid. However, the blood concentration is very low, and TG cycline is a poor drug for bacteremia. TG cycline is also a poor drug for UTI. Although tigecycline is a great drug for intra-abdominal sepsis, there are concerns regarding its use for biliary sepsis. Again, tigecycline monotherapy is not recommended. It is a bacteriostatic drug. It is always to be used in combination of other drugs where we are anticipating an abdominal infection. Not a drug of choice for UTI, even if it is sensitive, because you require almost 400 milligram doses to reach urinary concentration. You have better drugs to treat UTI. This is the summary of evidence for using prolonged infusion in intensive care. There is a lot of research which is going on whether to use infusion, but there is a recent papers which goes a lot in favor for higher doses followed by a continuous infusion. Somebody is practicing 2 gram of meropenem stat followed by 3 gram infusion over 24 hours. Somebody is practicing 2 gram followed by 1 gram infusion for every 4 hours, 8 hourly. So these are the research which has come across, and probably there is a lot of positiveness for doing infusion practices and higher doses. Probably that is going to have a better outcome. So we faced increased level of bacterial resistance worldwide. We must have a strong antimicrobial stewardship program for ensuring appropriate use of antibiotics. Few options for antibacterial drugs will be available in the future. Optimizing current antimicrobial treatment is must. Understanding PK alterations among the critically ill patient as well as PK/PD parameters associated with antimicrobial efficacy are essential for improved treatment of bacterial infections in ICU. So again, I want to have more emphasis. I think we all are trying our best, but still the PK/PD principles and the debate is quite open in ICU where we are looking at. And MDR is the major challenge where we are anticipating worsening, clinical worsening, as well as polypharmacy of antimicrobials. Thank you.
Dr. Anil, for reflecting our knowledge about PK/PD of antibiotic. During our clinical practice, also we found that it's very tough. Even we start stewardship program in our unit, and we found it's very tough to explain to the primary consultant what antibiotic when to use, and your this PK/PD with antibiotic surely will help all of us to achieve our goals. Now session is open for the question and answer from the audience. If anyone is can write their hand.
Even I want to add a point, like especially those patients on sepsis having a good urine output with creatinine of 2. As soon as somebody takes a round, everybody is trying to focus on creatinine. Nobody is trying to look at the urine output, which is appropriately 2 liters of urine output. You are reducing your cholesterol to 1 MIU. Probably that should not be there. In my clinical practice, I have utilized a higher dose of cholesterol in a patient who is oliguric. There is urine output 1600 ml, 2000 ml. We should not reduce the dose of any antibiotic, at least for first 72 hours. and I have seen a significant change in the outcomes. I really have a tough time to explain to some of the nephrology colleagues, because as soon as they calculate the creatinine clearance with MD-Cal, immediately the dose comes out to be meropenem 500 milligram BD. The cholesterol comes out to be 1 MIU TDS. Probably you keep this patient for 10 days in your ICU and you are not having a good outcome. This is what a clinical perspective which I have seen. I have also seen few nephrologists, especially in Fortis and Max, they also feel you give a higher dose as long as there is urine output. Don't worry about the kidney deterioration. If required, we will dialyze this patient. Probably that kind of an approach works very well in case of a patient who is deteriorating or struggling with sepsis. As we say, the best appropriate time, best appropriate antibiotics, and better understanding of PKPD is going to change the outcomes of sepsis. I don't say every patient will be treated appropriately. Every patient will have a best outcome. It's a lot of physiology and challenges which come across. But these are concerns which I have personally faced. I do face in my clinical rounds with nephrology team, with medicine team, with pulmonology team to explain. And sometimes me myself is irrational in choosing an antibiotic because my culture is going to take a longer time. By the time they report it is something which is unusual, we are losing our patients. So we are trying to escalate your antibiotic plan. These are some clinical areas. I hope everybody will be agreeing to my experience.
In the initial part, I said the 4 times of the MIC.
Yeah.
So how did we reach to that number, that 4 times MIC, not 3 times, not 5 times?
I think I don't have the real answer for this. I think we always want to have the higher concentration. Okay. Okay. 4 times the MIC. Thank you.
Thank you so much, Dr. Anil Kumar, for this PKPD of antibiotics insights. Now, I request my chairperson to invite our next speaker for the session, please.
As we know that during the phases of our life, everyone should teach us one line that be positive. But when it comes to the matter of doctor, and especially in the critical care area, this gram positive things is not always positive. So we have our next very experienced speaker, Dr. Vishal Gupta, who is a senior consultant and head of department of CCM Yashoda Hospital, Noida Extension. Sorry, Sarvodaya Hospital, Noida Extension. He will tell us about the management of gram positive infections, especially in critical care.
Good afternoon, all esteemed faculties and delegates and the chairpersons. Thank you, Dr. Amit and the Department of Critical Care Medicine and the Medicine Department for conducting this wonderful conference with a very needed topic, the much needed topic of the era, sepsis. So I'm going to talk about the gram-positive infections management in the ICU. So it is not so common than gram-negative bacteria, but it is very much needed topic. It will not work. Okay, right. So let's start with a case. A 60-year male, a known case of COPD, presented to the ER with a complaint of shortness of breath for 1 day and a productive cough for 5 days and for 3 days and high-grade fever for 5 days. And he had a past history that he was discharged just 14 days back, admitted for a H1N1 pneumonia. So in ER, the vitals were heart rate was 118 and BP was borderline 102/56. And on auscultation, there were crepitations at the right inframemory region and the basal region and infrascapular region. The saturation was 86% on the room air. The TLC came out to be 24,000 with the neutrophils predominance, and CRP was raised. So, what could be the diagnosis? It's very easy. Anyone? Yeah, it's a right lower lobe pneumonia. Now, so what should be the considerations for the choice of antibiotic in this particular patient? Anyone? Question is open to the house. In this particular patient, what should be the appropriate antibiotics to be started? Anything peculiar? Sorry. Okay. Anything else? She, sorry, sir. Yeah. Yeah. Yes, you're right. Yes. Yeah. This particular patient has a prior history of viral pneumonia. So it's a risk factor for MRSA. Okay, and other risk factors are also present in this patient, as he was hospitalized for almost 2 weeks. So there are risk factor for gram negative also. But it is proven that viral pneumonia patient has more chances of getting the MRSA infection. So we have started empirically injection piperacillin tazobactam to cover the gram negative bacteria and the vancomycin to cover the MRSA. So later on, the sputum culture showed Staph aureus, which was sensitive to vancomycin. And yes. Yeah, atypical bugs, but it's a more common. We have to cover the gram positive also. But it's a MDR. Atypical organism will not come in the MDR, I think so. Yeah. So later on, sputum culture showed Staph aureus, which was sensitive to vancomycin, and it was resistant to methicillin. So injection piperacillin tazobactam was stopped, we de-escalated, and vancomycin was continued. So our patient responded to the treatment. Now, can we have this? ये black वाला हट जाएगा क्या ऊपर से? ये जो आ रहा है नहीं, heading कट रही है. So this was a study published in NAGM. They have conducted study over 5 years. So what they found that MRSA and the ESBL, they are the majority of the infections. So you can see in the A block that is MRSA and vancomycin resistant enterococcus. This both are the gram positive bacteria, and the below one are the gram negative. The incidence of the vancomycin resistant enterococcus, incidence of the VRE and MDR pseudomonas was decreasing, but the majority was the MRSA and the ESBL. Now, in Indian study, the ICMR has also conducted a study. They found out that the Staph aureus and the Enterococcus faecalis incidence in the ICUs were around 13%. Other 87% were gram negative. Gram negative bacteria were more common. So WHO has also taken the gram positive infection in a high priority list for antibiotic stewardship program. Gram negative are the critical one. So coming to the basic about the gram staining, the gram positive bacteria take the stain, purple stain of the gram stain. So they comes to be purple, but gram negative bacteria does not take the stain. So they are pink. So microscopically, we can see gram stain, gram positive is purple. Why? Because gram negative bacteria have a outer membrane, this which is made up of lipopolysaccharide, this green one, and they have a porine channels and the peptidoglycan layer, which is this purple one. It's a single one. While in gram positive, the outer membrane is absent and the peptidoglycan layer is thick. So the gram positive bacteria takes the stain. So the gram negative bacteria, the lipopolysaccharide is the endotoxin which tells their virulence. So gram positive bacteria are divided according to the shape. The rod ones are known as bacilli, the circle ones are known as cocci. So we are concerned in the ICU only for two bacteria, the main cocci, the Streptococcus and the Staphylococcus. So Staphylococcus are clustered and Streptococcus are present in a chain. So Staphylococcus, if they are Coagulase positive, they are Staph aureus, and if it is they are Coagulase negative, then they are Staph epidermicus and Saprophyticus. While the Streptococcus, they depend on the hydrolysis in the agar plate. If it is alpha partial hemolysis, then they are alpha hemolytic. If it is a complete hemolysis, then they are known as beta hemolytic. And if it is no hemolysis, then they are gamma. So Enterococcus comes in the gamma hemolysis. So in ICU, Enterococcus infection and the Staph aureus infection are very common in per se gram-positive infections. So Staph aureus are facultative anaerobe and cocci in shape. They forms large, round, golden yellow colonies on the blood agar, often with they cause hemolysis. Cells are arranged in the cluster. They are commensal in the human microbiota. Staph aureus normally colonizes and they survive for a long time on the skin. You can see they are more prevalent in the perineal area, 60%, and forearms. So hand hygiene is very, very important. So they are normal colonizers. So as for regarding the treatment of the Staph aureus, initially there was no antibiotic. Whatever the boil or abscess come, they used to cut and release. After that, in 1940, penicillin injections were introduced, which inhibit the cell wall synthesis of the bacteria. So you can see in this uh, uh, chart, whenever an antibiotic has been discovered or developed after 2 or 3 years, the resistance has developed to that antibiotic. Just because there was over rampant use of the antibiotic, unindicated use of antibiotic, or there was no de-escalation. So we are facing now the last cycline has also got reported as a resistant. So there is no new antibiotic at present in the pipeline. So what is MRSA, methicillin resistant Staph aureus? The Staph aureus bacteria which are resistant to the oxacillin, nafcillin, and methicillin. So methicillin or oxacillin resistance is defined as an oxacillin MIC more than 4 microgram per ml. And the MRSAs who are resistant to oxacillin and methicillin are also resistant to all beta-lactam antibiotics, including cephalosporins. So these are new cephalosporins fifth generation, which are the exceptions, ceftaroline and ceftobiprole. MRSA was first identified in 1961, and the incidence ranges from 11.5% to 60%. Now, what happened in penicillin binding proteins are present in all gram-positive bacteria. They bind the peptidoglycan layer. So the beta-lactams, the antibiotics, what they do, they bind to the penicillin binding protein to inhibit the cell wall synthesis. So what MRSA, how they got mutated? MRSA, they had a MAC-A gene. What this MAC-A gene got mutated, and what they did, they code a different form of this penicillin binding protein, which is known as PBB2A. So when this PB2A is produced, the binding of beta-lactams got hindered. They never bind to that layer. So there is no cell lysis, and then this PB2A got incorporated, and they used to form the new MRSA has developed. So the cell wall is made up of this PBB2A. So this MAC gene, which got mutated, which I told in the previous slide, this is a part of a mobile chromosomal element known as staphylococcal cassette chromosome. So there are 12 different type of SCC. Type 1, 2, 3, 6, and 8 are associated with the hospital-acquired MRSA. And they contain genes that encode resistance to other antimicrobials also. And community-acquired MRSA has a type 4-1, which is less resistant. Now, as per se, MRSA, we have two types, community-acquired and hospital-acquired. So community-acquired infections are acquired by the persons who have not exposed to the medical care in the past 1 year. So this community-acquired MRSA, they manifest as skin infections like pimples, boils, soft tissue infection, and they occur in otherwise healthy people also. They are resistant only to the beta-lactam agents and erythromycin, and they can be treated with other antibiotics like clindamycin and trimethoprim sulfamethoxazole, which we know as Ceftriaxone. So most community-acquired strains frequently carry type 4 and 5, and they have PBL cytotoxin also that cause increased prevalence in CA-MRSA bacteria. So who are the people who are at the risk of community-acquired MRSA? The inmates, prisoners, athletes, military recruits, children. Now we come for the hospital-acquired MRSA. This this happens in the patient which take a medical care. So risk factors are surgery, dialysis, hospitalization, or indwelling drainage catheters, central line dialysis catheter, or the patient who had previously grown MRSA. So they are often resistant to other antibiotics like erythromycin, clindamycin, and tetracycline. So drug of choice is vancomycin in them. So hospital-acquired MRSA will occur in VAP cases, COTY, and bone and joint infection, endocarditis, while the community-acquired causes cellulitis, necrotizing fasciitis, bone and joint infections, necrotizing pneumonia. So how do we prevent it? How do we prevent the transmission, control the transmission or prevent the occurrence of MRSA? By hand hygiene. This is the most important part, which we often see that almost 80% of people are not rubbing the hand before touching the patient, and after touching the patient also they are not cleaning their hand with the sanitizer. So this is very important to prevent the transmission of the bacteria, MRSA or any gram-negative bacteria which are MDR. So contact precaution is also important, and patient bathing with chlorhexidine has been shown to be useful to decrease the MRSA colonization. I saw in the first slide that the perineal area and the armpit and the hand are the most common areas where the Staph aureus bacteria used to stay normally. In nasopharynx also, we can see some MRSA bacteria are here if patient has that the risk factors. So decolonization is also important with mupirocin ointment 2%, which we use for BD. If the patient has infection, which the patient has swab positive with MRSA and has some clinical signs of other infection also. So we have to use mupirocin also. So environmental cleaning and of course the antimicrobial stewardship is very important. So these are the some recommendations which I will tell. They are published in Infectious Disease Society of America in 2011 about the management of MRSA. So MRSA causes this skin and soft tissue infections like impetigo, folliculitis, cellulitis, and boils. So normally if patient is not so sick, OPD patients, so we can do in IND only, incision and drainage. There is no need of antibiotic. If there are any signs of complication like patient has any organ failure admitted in ICU or ward, organ failure is there or some extensive involvement is there, sepsis, then vancomycin, of course, we have to add it. Alternatives are linezolid, clindamycin, daptomycin, and ceftriaxone. Now, this is one very dreadful condition, toxic shock syndrome. It results from the elaboration of the toxic shock syndrome, toxin 1 and other exotoxins. They activate T cells and there is a massive surge of cytokines, which causes the multi-organ involvement, and fever can be there, hypotension, erythroderma will be there, macropapillary rashes will be there. Mucosal involvement is very common, and desquamation of the skin occurs during convalescence period, usually 1 to 2 weeks after the onset of illness. It happens in the 90% of the menstrual cases where they use tampons, and other also cases enterotoxin B is involved. So you can see, we can see the hand, there is a desquamation. So this is a clinical criteria to diagnose the TSS, and there are five criteria in that. This all five should be there: fever, rash, desquamation, hypotension, and multi-organ involvement. And the other one is the laboratory criteria. The serological test for Rocky Mountain spotted fever, leptospira, and measles should be negative, and blood culture should be negative with CSF. So we can confirm case are the case that meets the laboratory criteria and in which all five of the clinical criteria are fulfilled, including desquamation. Now, bacteremia, if MRSA bacteremia happens, then the mortality rate goes up to the 60%. So if patient has uncomplicated bacteremia, so uncomplicated bacteremia means resolution of the fever or systemic sign of infection by day 3 of the therapy, sterile blood cultures within 2 to 3 days of initiation of antimicrobial and the other. So in that we give vancomycin or daptomycin for at least 2 weeks. If complicated bacteremia are there, more organs are involved, and extensive metastatic sites are present, then we have to use the MRSA therapy for 4 to 6 weeks. So ticoplanin and vancomycin have the same spectrum of activity and efficacy. Linezolid has found to be inferior when compared to vancomycin, and there is no role of combination therapy in bacteremia. For infective endocarditis, if MRSA and endocarditis happens, then the mortality is around 30 to 37%. Right-sided endocarditis occurs in intravenous drug abusers and intravenous catheters. And if there is a tricuspid wall vegetations, then they can have a pulmonary emboli causing nodular infiltrates and the cavitating lesions in the lung. And patient with the involvement of mitral and aortic wall, metastatic sites will be involved. Other organs will be involved like joints, kidney, brain. So the treatment for infective endocarditis is vancomycin. Again, if there is a native wall endocarditis, the treatment is 6 weeks. And if there is a prostatic wall endocarditis, then vancomycin and rifampicin is given for 6 weeks, and gentamicin should be given for the first 2 weeks. The combination therapy is given if there is a prostatic wall endocarditis. And clindamycin and linezolid should not be used to treat endocarditis due to their poor outcome. Pneumonia, it is characterized by severe respiratory symptom, high fever, pneumoctasis, and rapidly progress to sepsis and septic shock. The special radiological features are cavitatory lesion, empyema, pyeopneumothorax, and pulmonary hemorrhage and microabscess can also occur. The mortality is very high, 30 to 40%, and treatment is again vancomycin or linezolid and clindamycin if it is a CA-MRSA. Again, we should de-escalate the antibiotic. We should not continue antibiotic for, say, we can say 14 days de dete hain. No, we should not give that. It will create a resistance again. So always use Procal to de-escalate the antibiotics, not to diagnose the bacterial infection. It is not recommended for diagnosis of the infection. It is only recommendation is there only for the de-escalation of antibiotic, not the escalation of antibiotic. Or if you are in doubt, what infection is there, why this patient is not improving after giving antibiotic, then you can use procalcitonin. But there is only one level 1 evidence of procalcitonin. You have to use it only in de-escalation of antibiotic, not to diagnose. So again, if there is a meningitis, vancomycin for 2 weeks. If there is a shunt present, then we have to remove it. If abscess is there, then we have to remove the abscess in season and drainage. We have to do, and the vancomycin treatment is for 4 to 6 weeks, and for bone infections, 8 weeks. So these are the drugs which have activity against MRSA. So I have written some small side effects. Vancomycin, of course, it's a drug of choice for MRSA. We have to monitor the serum throw levels, and the side effects are Redman syndrome and nephrotoxicity. For daptomycin is contraindicated in pneumonia because daptomycin get inactivated by the surfactant. And we have to measure the levels of CPK on initiating the daptomycin because it causes myolysis. Ticoplanin, it's again bacteriostatic. It has similar efficacy as vancomycin. And linid, the thrombocytopenia is common after 3 weeks of therapy. Serotonin syndrome can occur, and it causes lactic acidosis also. Rifampicin should not be used as a single agent. It is used only in combination, that too in endocarditis patients. And these are 5th generation cephalosporin, ceftaroline, and ceftobiprole. Ceftaroline is also active against Enterobacteriaceae. So these are some recommendations by the ITSA, Infectious Disease Society of America, regarding the vancomycin dosing and monitoring. So the dosing should be 15 to 20 milligram per kg. Actual weight, it can be divided into 8th hourly or 12th hourly. And the single dose should not exceed 2 grams. In seriously ill patients, like in meningitis, pneumonia, or infective endocarditis, A large dose can be given as a loading dose, around 25 to 30, but we have to be very careful. Red man syndrome or anaphylaxis can occur. So we have to give the infusion on for 2 hours if we are giving a very high loading dose. And the throw concentration of vancomycin should be monitored, and it should be monitored before fourth or fifth dose to achieve the maximum concentration and time dependent, and reduce the nephrotoxicity. For serious infections, vancomycin throw concentration of 15 to 20 microgram per ml are recommended. And this too monitoring is done in serious infections and patients who are morbidly obese and who have renal dysfunction, or there is a fluctuating volume or distribution. And the other patients who have normal renal function, not obese, normal dose 1 gram BD we can give, and there is no need to do throw concentrations. And continuous infusions are not recommended of vancomycin. And how should the results of vancomycin susceptibility testing should be used to guide the therapy? For isolates with vancomycin MIC of less than 2, the patient clinical response should determine the continued use of vancomycin. If a patient has a clinical and microbiological response to vancomycin, then it should be continued in the case of MIC less than 2. And if a patient has no clinical or microbiological response to vancomycin, despite doing all debridement and removal of this, alternative to MIC is recommended. The MIC came out to be less than 2, but patient is not responding. So this is known as MIC creep or hetero visa is vancomycin intermediate staph aureus. It's the type of MRSAs, which I will tell you. So they have, in this patient who have MIC less than 2, some patient will respond, some will not respond. The persons who are not responding, in them MIC creep, what does it mean? We can see Dr. Anil has described this time-dependent killing. So the MIC is, you can see there is a MIC creep. The MIC has gone up from the normal level. It has gone up. So why it happened? There is a mutation in the genes like WOC-R and VRARS. What they do, the peptidoglycan layer, they got more thickened. So due to excess of the free residues of D-alanine and D-alanine, these free residues, they act as a distractor for the vancomycin. So they bind to them, but they do not go to the target site of the bacteria. So the bacteria doesn't get killed. So MIC creep is there. MIC has increased. So what we can do, we have to change the therapy. We have to add some new gram-positive antibiotic. The second is when MIC is more than 2, there are vancomycin intermediate S or ES in VISA which have MIC of 4 to 8 or VRSA MIC of 16. An alternative to vancomycin should be used. Now, what is the management of this patient persistent MRSA bacteremia and vancomycin treatment failures? We have to remove the foci of the infection. Drainage or surgical debridement should be done. Or high dose daptomycin 10 milligram per kg per day we can use in combination with another agents like gentamicin, rifampicin, linezolid, Septran or beta-lactam antibiotics. If there is a reduced susceptibility to vancomycin and daptomycin, then cuniprostin, dalfostin or linezolid or Septran can be used. Now, again, our case, our patient was doing well. Pneumonia got resolved because of vancomycin we have started, and patient was planned to shift to ward next day. Central line was inserted previously, it was removed, and the culture was sent previously. On the day of shifting to ward, culture showed Coagulase negative staph aureus. You have planned to shift the patient to ward. While shifting, you got the culture ki patient has cons in the blood. अब क्या करना है? अब फंस गए. Now how to approach this? Period. I will say cons are the normal flora on the skin and have relatively low virulence, and they form biofilm also on the central line or any catheter. So what we do, if patient is stable, you are shifting the patient to ward. Patient has cons in the blood. and there is no sign of infection. Patient is absolutely fine. So what we should do? We should ignore it. Okay, patient is very stable. There is no sign of infection. But if patient is immunocompromised or has indwelling catheter and signs of infections are there and with no alternative source of infection, then we should remove the saline and antibiotic vancomycin should be added to treat the cons. Now this is the last case. Just bear me for 5 minutes more, 5 minutes. This is a 70-year-old patient who was operated for perforation peritonitis. Resection and anastomosis of jejunum was done. There was a perforation in the jejunum and he was shifted to ICU from the OT. He was on Norid infusion and on ventilator. He was started on antibiotic piperacillin, tazobactam and metrozil. Norid gradually tapered off next day and the patient got extubated and he was shifted to ward next day. On POD2, he was shifted to ward. On POD5 in ward, he developed high-grade fever with borderline BP. Abdomen was tense and tender, and abdominal drain has first leg discharge. First was sent for the culture. On CT abdomen was done. There was a collection near the site of operation. Okay. Now, what organism you will suspect and what antibiotic you will give? Yeah, man, I'm presenting gram-positive infection. You have to think gram-positive. Eh? Enterococcus, right? So Enterococcus is a diplococci and it occurs almost everywhere in nature, common inhabitant of GI. So I have put this question. And concentration in stool is up to 10 to the power 8. So they are oxidase and catalase. Again, for Enterococcus, whatever antibiotics are discovered, this is a history. All the antibiotics discovered after 2 or 3 years, they got resistant. So this is all the history. So there are two important Enterococcus species. One is fecum and one is fecalis. Fecalis is relatively less resistant, but more pathogenic. They causes majority of the VRE and 10% of the isolates are vancomycin resistant. You can see 10% are only resistant, but even them, they are the majority VRE among both of them. There is more than fecum. So fecum are more resistant. They causes less infection and 80% of them are vancomycin resistant. So they have the similar resistance mechanism. They are beta lactamases, the four mechanism alterations of the penicillin binding protein, drug influx pumps are there, and alteration of the porine channels through which the antibiotic enters into the cell. So they are intrinsic resistant to all cephalosporins, aminoglycosides, clindamycin, and septron, and they have acquired resistance regarding aminoglycosides and ampicillin and vancomycin. So these bacteria are rather, we can say they are hospital-acquired infections, enterococci. I will leave this. So these are vancomycin resistance, how it develops. This resistance is mediated by a VAN-A gene, alters the target site for vancomycin present in the cell wall. So you can see that the vancomycin molecule is there. None of the this cell wall precursor has a shape of that vancomycin. They've altered lock and key. It's not चाबी अलग है हो गई है. So genotypes, there are VAN A to VAN G genotypes are there. VAN A has high level of resistance to both vancomycin and teicoplanin. VAN B has low level of resistance to vanco and they are sensitive to teico. And VAN C, they are intrinsic resistant to both. So we are more worried about the VAN A gene. You can see all are acquired except VAN C. That was intrinsic and all are acquired genes. So they have a high MIC, vancomycin 64 to more than 10,000 or teicoplanin also MIC is very high. So this is the most common gene we can find it in the enterococci. So there is a selective pressure also on bacteria. The if we have given some antibiotic to a bacteria, all the bacterial cells die, but antibiotic resistant organism will be there. So selection pressure is there. So they mutates and they overgrow. So enterococci are normally inhabitants of gut microflora. Repeated or prolonged exposure to the broad spectrum antibiotics and effective antibiotic like vancomycin, there's a selective pressure which causes massive colonies of enterococci, which with time develop resistant mechanism towards most drug by mutation. So there's a transmigration into sterile body components, and they causes SSI, UTI, bacteremia, infective enterocolitis in susceptible host, and they they transfer their gene. The VRSA occurs because VRE gene has been transmitted from plasmid to the Staph aureus. So one of the mechanism of resistance in Staph aureus is the transmission of the plasmid from the VRE. So again, we have to maintain the hand hygiene, and healthcare workers and most consistent source for transmission of this VRE. So again, they have mostly they are all hospital acquired infections, bacteremia, UTI, intra-abdominal and pelvic infections, which I told in the case. And infective enterocolitis again is the third most common cause of native valve enterocolitis after staph and viridians. So mostly they occurred endocarditis by fecalis is associated with central lines, liver transplant, and mitral valve infections, and fecum is associated with the infection of tricuspid valve. But they have a typical subacute course of IE. So these are the drugs which European Society of Cardiology has told for beta-lactam and gentamicin susceptible strains, amoxicillin and gentamicin, amoxicillin with ceftriaxone, or vancomycin with gentamicin. They have one level 1B and 1C recommendations. And this is the last slide. This is all the crux of VRE treatment. Ampicillin high dose plus minus aminoglycosides remain the first line therapy for all susceptible VRE infections. Ampicillin with ceftriaxone combination is given for infective endocarditis, for serious infections, including bacteremia caused by ampicillin-resistant VRE with high level of resistance to aminoglycosides. The preferred drug for serious infections, for including bacteremia, is for bacteremia linezolid daptomycin, for infective endocarditis daptomycin, for CNS linezolid and daptomycin, for intra-abdominal linezolid daptomycin or tigecycline. Tigecycline, Dr. Anil has described that it has a very high concentration in the tissues or intra-abdominal compartment. So it's a very good drug if it is given in a combination for VRE, intra-abdominal sepsis. So Linate versus daptomycin for VRE bloodstream infection, Linate is better. It's proven in most of the studies. So thank you. So what doesn't kill you? What doesn't kill you mutates and tries again to kill you. So we have to keep improving. Thank you.
I just want first one doubt here.
Yeah.
That, nowadays we are in post-COVID era.
Right.
So post-COVID, last year we had seen maximum number of our population go to either level 2 or level 3 viral hepatitis. So now, how could it is to use vancomycin just on suspected bacterial infection, or we should wait for culture to come positive, or we still go for broad spectrum antibiotic or with along with it?
See, post-viral, if you are saying per se about the COVID era, any viral infections, they have a predisposing, they are the predisposing factor for MRSA to occur. So whenever you go through the literature, they are saying that either it is a H1N1 infection or dengue infection or this COVID, they all are they are very prone to get a MRSA infection. And of course, we have to keep it in mind the gram-negative infection also, because the patients are hospitalized there. So we have to cover both MRSA and MDR negative, gram-negative bacteria. So if a patient with a previous history of hospitalization within 90 days or previous antibiotic within 90 days, dialysis patient or the patient who is on pharmacare, then we have to consider both MDR, gram positive and gram negative. We have to take both in account. Yeah, thank you.
Sir, how many days of viral infection?
No, ma'am. In our case, it occurred after 2 weeks, and I had a colleague who got COVID in the second wave, and after 2 weeks of the COVID, of course, he got in COVID, the steroids and all. He was on 1 liter oxygen. He got a cavity in the lung after 2 weeks of discharge of COVID from the, and that cavity came out to be MRSA1, the sputum.
No, then for how long we should suspect that it is a superadded infection of this negative or gram positive?
Ma'am, if a patient comes with signs of infection, our patient came with sputum,
So
productive cough.
after 1 month also we can suspect.
Yeah,
this?
it's a 90 days time period for MDR risk factor.
So 90 days. is
90
the
days
limit.
means three
After
3
80
months.
Days, after 3 months, we shouldn't suspect this.
No, ma'am, very rare chances. In literature, it's very well written and studied that MDR risk factors are present for 90 days. So if there is a 90-day period of, if the patient has received some broad spectrum antibiotics, then we should consider.
Sir, I have a question.
Yeah.
Sir, in the previous presentation also, we were discussing about de-escalation of antibiotics.
right.
So can you give us some clarity about what do you follow in your
Uh,
clinical practice?
See, ma'am, for example, in our patient, for say, we say gram negative infection or gram negative, gram positive, we have started some antibiotic. Here, हम पहला patient ही अपना देख लेते हैं, first case in which we have started MRSA, vancomycin and piperacillin tazobactam. Patient has improved and the culture showed MRSA was there. So patient was improving. So at least according to the guideline of its or CDC or ATS, American Thoracic Society, or any guideline, they say for community acquired pneumonia, the 5 days therapy is sufficient. We have to see clinical response. And if you want to do, as I say earlier also, we have to guide the therapy through procalcitonin. We should not do the procalcitonin on the first day of admission if patient comes with a sign of infection and patient is in shock or in sign of infection, fever, productive cough and anything, abdominal pain, urine, burning nutrition is there. That means that he has an infection. So why to do a procalcitonin? I remember one case, no, ma'am. If Procal is normal, Procal can be normal. And I have seen multiple times Procal is normal on the first day, but patient has a infection, and after 2 days there is a there is a bacteremia. You see E. coli in the blood, or you see urine E. coli is there. So we cannot judge our treatment through a procalcitonin. If patient on arrival has a sign of infection, then we have to give antibiotic. If Procal is normal, will you stop the antibiotic? No, no. We have to give. For de-escalation, we have to do procalcitonin. It's a very, very, I think Dr. Amit will also agree. Procalcitonin is very misused. It's highly misused test, and it's costly also. So we have to see everything. We should use it on de-escalation. And if there is a serious infection, 7 to 10 days, you...
For de-escalation also, you need some baseline. Na? How you will judge that it is increasing?
See, for... No, ma'am, there's no need of baseline. Patient came with infection, he is in shock. That means the procal will be very high. One case I saw, एक case के बारे में बताता हूँ. Patient was growing Acinetobacter in the blood. Acinetobacter, it's a very highly virulent organism, and he was on multiple antibiotics. One of my junior, the DRNB student, has sent the Procal. Procal came out to be normal, 0.002. And patient has a Acinetobacter in the blood and in the lung. क्या मैं एंटीबायोटिक बंद कर दूंगा? नहीं करूंगा, क्योंकि क्लिनिकल ही हैज एन इन्फेक्शन and he has a growth in the blood and urine or anywhere.
Procal is normal on the first day.
Sorry.
On the first day, Procal is normal. We
Yeah.
know there is infection. We
Yes.
will not stop the antibiotic.
No, we have to give.
But after 3 days, if you are repeating the Procal,
Yes.
how you will be able to know it, whether it's increasing or reducing if you don't have done
Yeah.
it on the first 2 days?
Okay, right. So there is a flow chart of procalcitonin ka interpretation. If you have a baseline, and if there is a 80% decrease in from the baseline, if for example procalcitonin is 5 on arrival, and the procalcitonin after 3 days or 4 days came out to be 1, so you see it's falling. Your treatment is responding, but still it is not normal below the baseline. मतलब 0.5 से नीचे नहीं है. So we have to continue antibiotic. If procalcitonin is normal after 5 days, then you can stop antibiotic. I mean, it's very well. So many RCTs have been done. So many meta-analyses are there for procalcitonin.
But
So
Dr.
yeah,
Vishal,
yeah.
during the clinical scenario,
Yes, yes.
tertiary hospital like us,
Uh,
we usually get the patient from secondary hospital. They already taken the
Yes,
multiple
yes.
antibiotics, or at home
Uh-huh.
also they are getting the high antibiotics.
Mhm.
So when they are coming to the hospital, it's always better to do procalcitonin on day one and to tell the family that this is
Yeah.
because of the old hospital, not because of our hospital. One thing.
No, no,
that
no,
way, and
no.
See,
Sir.
I
Yeah.
believe procalcitonin should be taken with a pinch of salt. I mean,
Yeah.
we shall not jump onto any conclusion just
Yeah.
based on the procalcitonin.
Yeah,
As you
right,
mentioned that procalcitonin was 0.5 and the
Yeah.
patient grew Acinetobacter. No, Acinetobacter will not be treated. I mean, just
Yeah.
because the patient, the Acinetobacter is there in the blood.
Right.
If the patient has got the signs of bacteremia, sepsis,
Yeah.
septic shock, of course,
Right.
the patient will be treated, irrespective of procalcitonin being normal or high. Having said that, I mean, the procalcitonin should be taken into consideration. A trend, as madam has
Mm.
mentioned, a
Mm.
trend of the procalcitonin should also be taken into consideration. Yes, doing procalcitonin every second day or every third day
Mm.
for justification whether antibiotic should be stopped or not. No, that's not right. So it's better to go for a battery of tests. Other clinical parameters should be taken into
Right.
consideration,
You're
not
absolutely right.
procalcitonin. So we
Clinically,
shall
if
not,
patient is improving,
Yes.
then there's
so we
no
shall
need
not,
of
we shall
doing
not treat the
procalcitonin.
procalcitonin, we should rather treat the patient.
Yeah.
Yes, of course, there are literature, there are
Right.
several studies, there are RCTs as well, wherein procalcitonin has been shown to have a effect or I mean useful marker for de-escalation of
Yeah, right.
antibiotics,
Right.
not for the escalation
Not
of
for
care.
escalation.
See, the procalcitonin was 1 at the time of admission, and the procalcitonin rises to say 10. I
Hmm.
mean, this is what me and Dr.
Hmm.
Shruti discuss in
Yeah.
the ICU regularly.
Right, right.
That at the time of admission, we get a procalcitonin, which is 0.2.
Hmm.
And then after 3 days, we do at 20. So what do we do?
You do because the patient is deteriorating.
Right.
I
So
think you
at the
must be
time
doing
of
for that.
admission, yes,
Yeah.
at the time of admission as well, we have seen the
Uh.
patient is the patient was not in septic shock. The patient was in sepsis.
Yeah.
So there, the trend is going up. So at that point of time, we of course cannot stop the antibiotics.
Right. We have
But-
to rather escalate the antibiotics.
Yes.
But there is no need to do procalcitonin because
I would
patient
still
is
not
worsening.
take procalcitonin into consideration. I would rather
Right.
take the
Clinical
condition into consideration.
Right.
Dr. Ranil want to ask.
The focus is not only stopping the antibiotic, even if you are switching over, usually these patients are on 1 gram positive, 2 gram negative antibiotic when they are sick. If you are growing some source in 48 hours, which is gram negative, probably we should stop. The time is to stop Targocid, time is to stop vancomycin. If patient is able to take orally, he should be shifted from IV to oral. These are all de-escalation steps, but PCT per se should not be utilized for any escalation or de-escalation. I think if you have the serial trend, but everything involves a lot of cost.
Procalcitonin is very costly test, 5,000. We have to consider it.
So-
If there is a clinical worsening, of course, you have to escalate the antibiotic. If there is a clinical improvement, of course, you have to continue antibiotic for 5 to 7 days. If serious infections are there, then we have to continue it for 7 to 10 days. And if you are more concerned कि procalcitonin करना है, de-escalate करना है, patient का cost reduce करना है, antibiotic कम करनी है, do procalcitonin. I am very fond of procalcitonin. I disagree with my consultants over there, primary and all. He don't do procalcitonin. It's very costly test. And if there is a clinical sign, please escalate the antibiotic. And if there is any doubt, the patient is worsening and we are giving appropriate antibiotic rather than any other pathogen, then we can do procalcitonin. Patient might have a viral infection, might have a fungal infection. In that too, also procalcitonin rises, but not too much. It will be around 3 to 4, like that, not more than that. In
And
gram negative, it's very.
I will just add, all the RCT has been done in Europe, USA, and
Uh-huh.
Australia. And procalcitonin relative rate is cost is very less there. So it's as good as we are doing CRP here. Okay, so it's very easy to do the procalcitonin and see the trend and I mean do the interpretation, but it's not possible here.
No, it's
It's
very
cost is
its
too
cost
much.
is too much.
It's too costly a test to be done serially, actually.
ठीक. Yeah.
It is both our clinical judgment
And and that balance has to be established in any hospital.
Right.
We have to establish a balance and we have to think when to get these tests done.
Yeah,
Those
if
are not clinical tests.
yeah, if you are doing procalcitonin for de-escalation, you are saving the money of the patient. That if procal comes out to be negative after clinical improvement, then the antibiotic should be stopped and the cost will come down. Okay, we are giving very heavy
But
antibiotics.
just I would like to just say that like we are talking in the since the morning we are talking about de-escalation, de-escalation.
Right, right.
So like the Dr. Anil had said that we should not like with whenever patient comes with sepsis or any serious condition, we cover both gram positive and gram negative to cover the bacteria until we know the culture report or some indications. So otherwise, like so once the report is positive, for example, and if it is gram negative, so at least we can stop the gram positive.
Yeah,
cover.
that
Like in this case,
Yeah.
in your case,
Yeah.
it was a gram positive.
yes.
So you stop the
Yes, I
quotas.
practice that also. I am not written here. I practice.
That
I am
is also
practicing
part
that
of
also.
de-escalation.
Yeah.
But generally, it does not happen.
Hmm.
We still continue the piptas and then
So this is
vancomycin
how the resistance develop.
develop.
We are giving the antibiotic which is not indicated, so we have to stop it.
Yeah, so that is also part of de-escalation.
Yeah.
Also, like if it is if we know the source of infection, like syndromic approach we do, like sepsis is due to maybe saying the pneumonia. And if we know that in our case, like in our ICU, the most of the time it is gram negative bacteria, Hana, and it's matching. So that also helps. And so we have to correlate everything, and then we should decide the antibiotics and the types of antibiotics, and then we should take a call on that. And also switching to the oral therapy, that is also part of de-escalation. You
Yeah.
have to think about that when the patient is improving.
Thank you. Yes. Yes, sir. Thank you.
Sir, I have just one question. Basically, we're talking about de-escalation.
Yes.
So if the patient started empirically on vancomycin, seeing the risk factors,
Yes.
what is the role of doing a nasal swab for MRSA? That comes in one day.
They that is doing for the MRSA swab for the nasal. This is doing
For
we
the
do for
colonization.
surveillance purpose.
But if you do
For
it
surveillance process on the first day.
if you do on the first day, if it
Yeah.
is we send a nasal swab for every patient suspecting MRSA, and if it is negative, we can stop the therapy. Is it like what do you say on that?
No, that is only for surveillance purpose, that MRSA one. If patient, if in this
in
patient, if
one.
we have sent, then we have to start the antibiotic
If
also.
it
We have
was
started
negative,
only.
If it was negative, the culture sometimes may be
Yeah,
negative.
that's no issue. Nasopharynx में
should
भी
be
होता
sent
है,
regularly, like-
armpit में होता है, perineal areas में होता है.
So-
बहुत सारे areas में MRSA होता है. If you have to do surveillance, we have to send at least 3 sites.
One other question, sir, if vancomycin levels, MIC levels are more than 1, as per
Yes.
the latest guidelines, we should not use vancomycin. That's not the 2. If it is more than 1, we should not use it.
More than one,
One.
what?
MIC levels.
MIC more than one?
Yes. As
No,
per the latest guidelines of ITSA in 2020, I think it came.
2011.
20
yeah.
came.
Okay. MIC more than one?
One. You should not use it because you will achieve, you won't be achieving the clinical effect. It will be already leading to clinical failure,
Mhm.
and side effects will be more.
MIC, we are taking the MIC as a less than 2.
That is
then
for sensitivity.
for sensitive one.
But if it is more than 1,
Mhm.
you should switch to another antibiotic.
No, it's more than 2, I think so.
It's one.
It's one. Oh,
It's one.
thank
As
you.
per the latest,
Okay, okay,
I think
right.
it came in
Okay.
2020.
Okay. So more than one for this MIC creep, I think so. They have told like this. Yeah, yeah. Right. And yeah, I think. And there is a overgrowth of H visa also, na? MIC creep is also there. Might for that I think so they have done. Yeah.
I'll request the chairperson to close the session because we are running behind the schedule. So
Thank
we'll
you.
discuss it in the lunchtime. Thank you. Thank you.
Thank you so much, sir, for such a knowledgeable session. I request my chairperson, Dr. Shruti, Dr. Sunil, and Dr. Snigdha to kindly felicitate our speakers, Dr. Anil Kumar, Consultant and Head CCM Santosh Hospital, Ghaziabad. A huge round of applause, everybody, for Dr. Anil Kumar. Next, Dr. Vishal Gupta, sir, please come on stage. A huge round of applause for Dr. Vishal Gupta, everyone.
I believe all the question has been asked to Dr. Vishal Gupta. Nothing is left for Dr. Prashant now. Even gram-negative question has been asked to
Round
Dr.
of
Prashant.
applause, everyone. Thank you so much. And to felicitate our chairperson, I request Dr. Manju Tyagi to please come on stage to felicitate our chairpersons. Ma'am, please come on stage. Huge round of applause for Dr. Manju Tyagi. Dr. Suleen Balyan, he is a consultant internal medicine, AMD Yatharth Hospital, Greater Noida. Thank you so much, sir, for joining us today. Thank you so much, ma'am. Now next, Dr. Shruti Sharma, consultant, internal medicine, Yatharth Super Specialty Hospital, Noida Extension. Dr. Snigdha, she's a consultant, internal medicine, Yatharth Super Specialty, Noida Extension. Thank you so much for chairing this session. Thank you very much, Dr. Manju Tyagi, ma'am. Now, coming over for the next session, I request to chair this session Dr. Manju Tyagi, Senior Consultant, Internal Medicine, Yatharth Hospital, Noida, to please come on the stage. Dr. Ashutosh Garg, Senior Consultant and Head CCM, Kailash Deepak Memorial Hospital, New Delhi. Dr. Dio Shankar, he is a consultant CCM, Fortis Hospital, Vasant Kunj, New Delhi. A huge round of applause for the chairpersons, everyone. So they'll be chairing a session on the topic gram-negative infection management in ICU and newer antibiotics. So I request you to please kindly announce the speakers.
Dr. Prashant Singh, good afternoon. The topic will be gram-negative infection. It's the management of gram-negative. We have listened a lot about gram-positive. बहुत difficult names लगे, but फिर भी इतने difficult नहीं थे. 2-3 ही नाम थे. स्टेफाइलोकोकाई, स्ट्रेप्टोकोकाई, एंट्रोकोकाई, at least याद हो गए. लेकिन अभी हम gram-negative की list सुनेंगे तो I think it is more difficult. It will be very difficult to pronounce them and to just remember them. Still, it will be a big job if he will be able to remember us few names. आईसीयू में जाते हैं हम बड़े आराम से स्टार्ट कर देते हैं टैजेक फिर पता चलता है नहीं द पेशेंट विल नॉट रिस्पॉन्ड समथिंग डिफरेंट हैज कम एंड व्हेन वी जस्ट ट्राई टू प्रोनाउंस द नेम इट्स मोर डिफिकल्ट सो वी से ओके लीव इट व्हाटएवर इट इज जस्ट टेल अस वेदर इट इज ग्राम नेगेटिव और इट इज एनारोब बिकॉज एनारोब्स के नाम थोड़े डिफिकल्ट हैं बट ग्राम नेगेटिव के तो बहुत ही डिफिकल्ट है वी जस्ट टेल अर पैथोलॉजिस्ट मैम आप बता दीजिए बस ग्राम नेगेटिव है ना एंड व्हाट वी शुड स्टार्ट. So when we start something, then another problem comes. The ICU person will come. No, ma'am, this will not be effective. There will be so many side effects. So I think sir will enlighten us to know what are the gram-negative organisms, which antibiotic we should start, and what side effects they can have. So please continue. Thank you, sir.
Yeah, thank you very much, ma'am, for the kind words. I will try to justify your faith in me. And first of all, I would like to, a very good afternoon. I would like to thank Dr. Amit Goel and all the organizers from Yatharth Hospital for this wonderful congregation of the sepsis conference. And a good afternoon to all the chairpersons, Dr. Ashutosh, ma'am, and Dr. Dio. I think there's a technical glitch. Just wait for 2 minutes.
the time he starts, I have missed something. He's a senior consultant in critical care medicine from Rajiv Gandhi Cancer Institute and Research Center. He has publications in various journals and chapters in books. Patient Duni Chand Award winner for best free paper at SGRH. And he has specialty interest in critical care, ultrasonography, and extracorporeal therapies.
Thank you, ma'am. Thank you. And first of all, I also thank Dr. Anil and Dr. Vishal for this wonderful talk on antibiotics, the PK/PD and gram-positive infections. Just I would like to just proceed on with the legacy. Thank you. Why gram-negative? This is available. This slide I've taken from Department of Biotechnology, Ministry of Science and Technology, Government of India. This in itself implies like the gram-negative bacteria, they are in the critical priority. Enterobacteriaceae, Klebsiella pneumoniae, E. coli, and non-fermenting bacteria, Acinetobacter baumannii, Pseudomonas, and we can add Stenotrophus, Strenotrophomonas multifili also in this. You can see these are all carbapenem resistant, tigecycline resistant, colistin resistant, carbapenem resistant again, colistin resistant again for non-lactose fermenting bacteria. My approach will be, I will just go on a targeted therapy rather than discussing the prophylactic and the empirical therapy. I will just go for case-to-case basis and try to ease things out for you. GNP is a predominant group infections in the critically ill population in the Indian subcontinent. Antibiotic resistance. Can anyone tell me how long, since how long are we witnessing this antibiotic resistance? 70 years, 75 years, 100 years? Anyone, any wild guess? कब से हम देख रहे हैं एंटीबायोटिक रेजिस्टेंस? कब से हम जूझ रहे हैं? Any guess? Pardon me? Yes, sir. I surely agree with you. This is an old phenomena. It dates back to 2 billion to 40 million years ago. This was also a surprise for me, but going through various articles and various books, since the advent of bacteria, or we can say since the advent of life, we are witnessing this antibiotic resistance phenomena. My case is, the first case is, 65-year-old male admitted with acute pyelonephritis, hemodynamically stable. The urine culture shows E. coli, the colony count 10 to the power 5. The culture report says ceftriaxone resistant, piperacillin tazobactam, the MIC4, it is sensitive, and meropenem sensitive, MIC 0.5. Just a question to the audience, which antibiotic will you start? Okay. Piperacillin?
If it is E. coli, then we can think of starting piperacillin tazobactam. If it is a Klebsiella, then more likely we should start with the carbapenem.
Okay, I agree with you. Thank you. Thank you very much. They also started with piperacillin tazobactam, and there was a study known as Merino trial, Merino 1. Just going by the this AMBER classification, just to classify the bacteria, classified as A, B, C, D. B is beta-lactamase, and A, C, D are serine positive. And the question is, what is the resistance mechanism in this, and which antibiotic will you choose? This is the Merino trial I was talking about, published in JAMA, I think in 2018. The effect of piperacillin tazobactam versus meropenem on a 30-day mortality for patients with E. coli or Klebsiella pneumoniae. This is a bloodstream infection, but we have taken it as a guideline for a benchmark for the UTI infections also. Working. Okay, fine. When the study was done, it was found that the carbapenems are superior to piperacillin tazobactam for ESBL producing organisms. There was a good number of patients, 379 patients with ceftriaxone resistant meropenem. It was found that piptaz dose was 4.5 gram QID. The meropenem dose was 1 gram QID. But when the mortality was seen, the 30-day mortality in the piperacillin group was 12%, which was very high. And the mortality in the meropenem group was just 4%. So the whole idea of carbapenem sparing drugs, it went down the drain. They were flummoxed. यार हम तो बात कर रहे हैं कि हम carbapenem बचाएंगे, हम carbapenem sparing की बात करेंगे, और यहाँ पे हमने किया, and this is totally opposite. We have started with piperacillin tazobactam, but the mortality was very high. So the IDSA, they conducted another trial. Okay, one more thing. My all the facts are based on these two guidelines by IDSA guidelines on the treatment of antimicrobial resistant gram-negative infections version published in 2000, 2022, 23. So when this was a trial run, association between MIC concentration of beta-lactamase genes and mortality for patients treated with peptides or meropenem from the Merino study. So they conducted this trial based on the Merino study. And the results were, any microbiologist with us? Yeah. जो IDSA गाइडलाइंस कहती है, या हमने अगर यूरोपियन सोसाइटी की हम माइक्रोबायोलॉजी की इन्फेक्शन डिजीज की गाइडलाइंस देखें, वहां पे दे फाउंड आउट, दिस स्टडी फाउंड आउट that there was a problem with disk diffusion and VTEC method. Not a big problem, but yes, this is not the gold standard one. उनके हिसाब से, and when they did these methods, the broad dilution method and the e-test one, for this was the main method. They found out that this was the gold standard one. And before coming over here, I had a word with my ID physician and the microbiologist and my hospital also. They were a bit skeptical about this, but for them, the VTEC was the standard one, the gold standard one. But both studies, one done by the IDSA, and it was further recommended or substantiated by the European Society. They both say the gold standard is a broad dilution one, and the false methods were with the disk diffusion and VTEC method. इसमें problem क्या थी? Suppose हमारी dilution आ रही है 1/16 है suppose, but machine दे रही 1/8. 1/16 पे piperacillin is resistant, but the machine is giving 1/8. So they started with piperacillin tazobactam. And we did with broad dilution method, it was later found out that the broad dilution method is the more reliable one, and they went for this. Again, returning to the fact, piperacillin, this is the fallacies of MIC. The piperacillin tazobactam MIC testing may be inaccurate and or poorly reproducible when ESBL enzymes are present, or in the presence of other beta-lactamase enzymes such as OXA1, making it unclear if any isolate that is susceptible to this agent is indeed susceptible. For these reasons, the panel recommends avoiding piperacillin tazobactam for the treatment of ESBL infections. And when they did this study again with test confirming with the broad dilution method, the mortality difference was not high. They straight away went with carbapenems. Again, the fallacy with the MIC values are not precise. They're reproducible only to 1 plus minus doubling dilution with the reference methods. Accuracy is in doubt with automated AST platforms. The MIC values they give it only at the fixed inoculum, and whereas in the body, the number of bacteria, the size of the body, that makes a difference. MIC values, they do not always reflect the clinical response. Lastly, presence of different carbapenimases may affect in vivo activity independent of MIC values. Kabhi, suppose there's a bacteria which is CRE, there are multiple mechanisms, multiple resistance mechanisms involved. So we can't take for one mechanism कि हम इसी mechanism treat करेंगे. कई बार होता है they are masked, they are not visible with the हमारी जो error reports होती है या हमारा bio panel है या respiratory panel है उसमें वो they are not visible in this. One question is like, this patient was empirically started on peptides, to which he responded. Should it be changed after the culture results? No. There are two schools of thoughts in it. If it is pure cystitis, uncomplicated cystitis, you go ahead with piperacillin tazobactam. There is no harm in it. But if it comes out to be complicated UTI, then straight away the guidelines say, आप piperacillin tazobactam बंद करें, you start with carbapenems. No doubt about it. What are the preferred antibiotics for the treatment of pyelonephritis and complicated UTI called by ESBLE? The approach is trimethoprim, ciprox, levofloxacin are preferred treatment options for pyelonephritis and UTIs caused by ESBLE. Ertapenem, meropenem, and imipenem celastin are preferred agents when resistance or toxicities preclude the use of these drugs. Aminoglycosides for a full treatment course are an alternative options for the treatment of ESBLE to pyelonephritis or complicated UTIs. Again, the recommendation, if piperacillin tazobactam was initiated as a complicated therapy for uncomplicated cystitis caused by an organism later identified as ESBLE and clinically improvement occurs, no change or extension of antibiotic therapy is necessary. But if it is pyelonephritis, you can straight away jump to carbapenems. What are the preferred antibiotics for treatment of infections outside the UTI? Approaches, meropenem, imipenem, or ertapenem are preferred for the treatment of infections outside of the urinary tract caused by ESBL. Ertapenem, hypoalbuminemia, any correlation? I've just taken this ertapenem just as a guideline thing for, look, as an intensivist working in this field for last 8-10 years, look, I'm not here for any primary team bashing. It is just like we have to work in symbiosis. Hello. Hello. Yeah. It is like, this is one of the drugs. Ertapenem is dependent, it is highly protein bound. There are many drugs which are highly protein bound. What happens is, what is hypoalbuminemia? Less than 2.5, the guidelines say less than 2.5 is hypoalbuminemia. Ertapenem is highly protein bound. So unless or until we have a good albumin levels in our body, अगर वो bind नहीं करेगा उससे, तो half of the ertapenem will be just going away in the body like this only. हम दे रहे हैं अपनी तरफ से drugs, but the albumin levels are very critical. So suppose they are 1, 1.5, 2, less than 2.5. So there will be no use of giving ertapenem unless or until the albumin level, the protein levels in the body are adequate, so that there is sufficient albumin in the body to which the ertapenem can bound and can cause it effects. A second case, a 65-year-old male, a reformed smoker, COPD, post-influenza, presented with severe pneumonia, hemodynamically unstable, sputum culture shows Pseudomonas aeruginosa. This is his culture report. The two glaring things which I want to point out is it is cefoxitin resistant and cefepime sensitive. Anyone? What does it point to? Yeah, it points towards MCT. I will explain the whole thing. The resistance mechanism, which antibiotic will you choose? AMC beta lactamase. This is again the table. AMC. These are the group of organisms which cause these infections. Pseudomonas, like these days, we must consider ourselves lucky if we find Pseudomonas compared to a Klebsiella or say a crab or E. coli. Pseudomonas are bit easy to treat these days. This data suppose that suppose cefepime for Enterobacteriaceae that produce AMC beta lactamase. And one more thing is that मैं बोल तो रहा हूँ इसमें कि AMC है, but in our setup, India, Delhi, हम जहाँ पे भी हैं, it is very difficult to find pure AMC. The AMC is always associated with ESBL. There might be 5-10% cases which is pure AMC, but the rest of the cases they are ESBL plus AMC. What does it say? Although observation studies say that cefepime outcomes are similar to carbapenems or AMC, unlike ESBLs. IDSA guidelines, cefepime suggested for infections caused by organisms at moderate to high risk of significant AMC production. This again, I'm explaining the whole thing. AMC producing organisms are resistant to cefoxitin. The culture report says resistant to cefoxitin. In ESBLs are usually cefoxitin susceptible. अगर ये ESBL होता तो cefoxitin हमारे वहाँ पे susceptible आता. And AMC pattern without any ESBL, you can go ahead with cefepime. Another thing is that organisms that produce AMC without any ESBL typically have cefepime MICs less than 2, and ESBL producers usually have cefepime MICs greater than 4. These are the group of organisms which are generally pure AMC, but this is not a dictum. This can be interchangeable. Klebsiella aerogenes, Serratia marcinis, Protea, Mojanella, Providencia, Citrobacter farinae, Enterobacter cloacae, these are AMC. And if cefepime is available and if cefepime is susceptible, you can go ahead with it. Otherwise, jump to carbapenems. Again, continuing with this only, carbapenems are superior to cefepime for ESBL producing Enterobacteriaceae, even when the test is susceptible for cefepime. Even if our cefepime की susceptibility आ रही है, but despite of that, because it is an ESBL, we'll again go for the carbapenems. Avoid cefepime for pulmononephritis, UTI, complicated UTI or infections outside of the urinary tract due to ESBL. Third case, a 60-year-old male with renal calculi admitted with acute pulmononephritis. Blood urine culture shows Klebsiella. Peptase resistance is there. Ertapenem resistance is there. Meropenem sensitivity, MIC of 0.5, cholesterol intermediate, as we already know. Which antibiotic? Will you classify it as CRE? यहाँ पे ertapenem is resistant, but meropenem is sensitive. How will you classify this? Sir, आप मत बोलना. Sorry. You classify it as CRE? Okay. Okay. Dr. Ahmed is absolutely right. The CDC defines CRE as members of Enterobacteriaceae resistant to at least one carbapenem antibiotic or producing a carbapenase enzymes. But despite of that, guidelines still suggest you can use meropenem at a high dose, extended infusion or a high dose meropenem. Go ahead with this. What is the preferred treatment approach for infections caused by Enterobacteriaceae isolates? Without carbapenase production that remain susceptible to meropenem and imipenem, but are not susceptible to ertapenem. The catch over here is कि carbapenase enzyme नहीं होना चाहिए. Even if it is sensitive to meropenem or it is resistant to ertapenem, the carbapenase enzyme must not be there. अगर आप in future you get a carba test also जिसमें आपके enzymes का resistance pattern आ रहा है, you don't go ahead. For infections caused by Enterobacteriaceae isolates that exhibit susceptibility to meropenem and imipenem, MIC less than 1, but are non-susceptible to ertapenem, MIC greater than 1, the use of extended infusion meropenem or imipenem is suggested, assuming no carbapenemase has been identified. Meropenem dose, which I'm talking about, if it is cystitis, we can give 1 gram twice a day, infused over 30 minutes. All other ESBL AMC infections, again, TDS over 30 minutes. All other CRE and crab infections, 2 gram IV TDS infused over 3 hours. Again, the same mechanism implies for ESBL, AMC and CRE and crab. This one question was to ask in the audience कि हम अगर extended infusion दे रहे हैं, high drug therapy दे रहे हैं, high dose दे रहे हैं. This, while just going through literature and various articles, this was a normal nomogram I found. It shows that पहले तो आपको पता होना चाहिए कि मेरे patient की creatinine clearance कितनी है और मेरे को MIC से कितना ऊपर चाहिए. मेरे को 8 चाहिए, मेरे को 12 चाहिए, मेरे को 16 चाहिए. Suppose MIC is 4 और मेरे को drug achieve करनी है 8. So this is the chart which generally followed in many countries. मेरे को यहाँ का नहीं पता, मैंने कभी use नहीं किया. I haven't used in my ICU also. So this is the drug which give. ये drug की आपकी doses है per day, 2 gram, 4 gram, 6 gram, 8 grams. So depending upon the creatinine clearance of the body और depending upon हमको कितनी achieve करनी है. MIC से हमको लगता है कि हमको पूरी body को saturate करना है meropenem से. MIC से हमको ऊपर जाना है ताकि we can kill all the bacteria. So you can go ahead with this chart. मेरे को इसकी reliability नहीं पता. Any experience of anyone of you who has used it? Continuing with this, meropenem should be avoided if carbapenemase testing is positive, even if susceptibility to meropenem is demonstrated. There is uncertainty about the accuracy of meropenem MICs in these scenarios, and use of meropenem may lead to treatment failure. Although studies indicate optimal treatment approach when phenotypic genotypic discordance exists, panel prefers caution. This is again, I just want to show something. Yeah. Suppose it is CRE. And this is the carba test, not available in India. I don't know. Microbiologist people will be able to tell. This is a lateral flow assay. It is slide which we use in like a TROP-T or a TROP-I or for NS1. We take a serum and we put a drop of the serum in it. And within 15-20 minutes, it will show the resistance pattern. Whether it is whether it is A, B, C, whether it is VIM, whether it is an AMC, whether it is an OXA, whether it is an KPC. Though it is very rare in our country. This is a question for the audience. This report I got from my hospital. There are two glaring things is imipenem is intermediate, almost resistant, and meropenem sensitive. Will you still go ahead with meropenem? So I would advise you go ahead with a high dose or extended dose of meropenem. Second was E. coli. इसमें उल्टा है, imipenem sensitive है and meropenem resistant है. So these are like food for thoughts, and this totally depends upon the clinical practice or your experience, because whatever I have read and whatever studies I've gone through, almost all studies IDSA guidelines होगी, European Society guidelines होगी, they only concentrate upon their country, whatever flora fauna is in their country. Or India में in tropical country, being a third world country, हमारा सेटअप बिल्कुल डिफरेंट है. So there is always a room for innovation. There is always a room for clinical experience and your expertise. The case for a 40-year-old male, diabetic, impaired renal functions, previous hospitalizations, admitted with lobar pneumonia, Klebsiella positive in blood and sputum, peptide resistant, ertapenem resistant, meropenem resistant, TG sensitive, and cholesterol intermediate. What resistance mechanism do you think, and what antibiotics should we use in this? Any further tests would you advise for this? Yeah. CRE. What is the mechanism of resistance? Additional test, antibiotics. Again, going with the AMBLA classification. Pardon me? Yeah, it is NDM. Around 60% is NDM. 30% is NDM. जो मैंने जो पढ़ा है, it is 30-30-30. Almost. मतलब not a fixed line. 30% NDM plus oxa, 30% oxa, and 30% NDM.
Type of bacteria, like if you're talking about Enterobacteriaceae, like
Okay.
Klebsiella and E. coli,
I agree with
then
this.
NDM is the predominant.
Predominant.
In
Yeah.
Western country, it is KPC.
It is KPC. India में KPC बहुत
नहीं, कम है. And then if it is we're talking about the Pseudomonas or the Acinetobacter, then there are different mechanisms like oxa comes, or that there is a efflux mechanism, or there is a membrane permeability. That's why the difference there is a.
It depends upon the bacteria also, what kind of bacteria and growing it in it. मैं इसमें इसी की बात कर रहा था. I was talking about.
Like it is a Klebsiella, so it should be mostly NDM. It should be NDM. Because then the empirical antibiotic recommendation, like today there is ceftazidime avibactam plus etronam combination, which is also now in CRE, especially in the Enterobacteriaceae group.
I'll come to the slide again. Yeah. This was ceftazidime sensitive. This is the test. Then we told our microbiologist, "Bhai, आप इसकी slide लगाइए." So it came out to be ceftazidime avibactam sensitive. Yeah. तो जब ceftazidime की sensitive आ गई, हमने की नहीं आगे. It should not be. इसमें नहीं की. If it is sensitive, yeah, it cannot be NDM. हमने नहीं की थी इसमें. What are the preferred antibiotics for the treatment of infections outside of the UTI? मैं उसमें अगली slide पे आऊँगा मैं ना. We'll come to the next slide. वो भी case ले रखा है ना. The approach is ceftazidime avibactam, meropenem, varobactam. I think it is not available in our country, and same with imipenem, celestine, and relibactam combination not available in our country. They are the preferred treatment options for infection outside the UTI, urinary tract, caused by CRE, when carbapenemase testing results are either not available or negative. Cipidorocol is another alternate treatment option. I think cipidorocol is not also available in our country. USA. Can we use high extended meropenem with polymyxin instead of ceftazidime avibactam? What does the guideline say? The panel advises against the use of extended infusion carbapenems with or without the addition of a second agent for the treatment of CRE infections when non-susceptibility to meropenem has been demonstrated. But I don't think that we follow these guidelines very religiously, because at the end of the day, we have to, we are the ones who witness the flora and fauna of our ICU. We know at the back of our hand what antibiotics work in our ICU. So yes, these are guidelines. They are over here to guide us, but these are not the dictums. What is the role of polymyxin for the treatment of infections caused by CRE? Polymyxin B and cholesterol are not suggested for the treatment of infections caused by CRE. Cholesterol can be considered as an alternative agent for uncomplicated CRE cystitis. The rationale behind this is the clinical data indicates increased mortality and excess nephrotoxicity associated with polymyxin-based regimes related to comparator agents. Concerns about the clinical effectiveness of polymyxins, accuracy of polymyxin susceptibility testing led to the CLSI to eliminate a susceptible category for cholesterol polymyxin B. The panel suggests that these agents be avoided for the treatment of CRE infections, with the exception of cholesterol as an alternative agent against CRE cystitis. Polymyxin B should not be used as a treatment for CRE cystitis due to its predominantly non-real clearance. What is the role of combination antibiotic therapy for the treatment of infections caused by CRE? Combination antibiotic therapy, that is the use of beta-lactam agent in combination with an aminoglycoside, fluoroquinone, or tetracycline or polymyxin. It is not suggested for the treatment of infections caused by CRE, which I don't think that we comply with it. What is the likelihood of emergence of resistance of CRE isolates to novel beta-lactam agents when used to treat CRE infections? The emergence of resistance is a concern with all the novel B-lactams used to treat CRE infections, but the frequency appear to be highest for ceftazidime avibactam. Recently, I've come across some cases. I got the reports from various hospitals, which showed that the antibiotics, they were resistant to ceftazidime and avibactam. The isolates which were over there with us, maybe Klebsiella or what, they were resistant to ceftazidime and avibactam. The resistance mechanism is such that there is hydrolysis of the ceftazidime, and there is insertion of amino acid chain in the ceftazidime molecule by the bacteria, and it leads to resistant ceftazidime. One more interesting thing we found out was there were patients. There was some case report in Italy about Greece, about 8 patients in a particular ICU, जिनको कभी ceftazidime मिला ही नहीं. They haven't received ceftazidime in their whole life, but they were ceftazidime resistant. तो ceftazidime के साथ ये है problem कि patients को कभी नहीं मिला जिंदगी में ceftazidime, but they come out to be ceftazidime resistant. Exact the theory behind this, the mechanism, I think it is still to be discussed and to be reviewed upon. What is the role of tetracycline derivatives for the treatment of infections caused by CRE? Although beta-lactam agents, they remain the preferred treatment choice for CRE infections. Tigecycline and eravacycline are alternative options when beta-lactam agents are either not active or unable to be tolerated. The tetracycline agents are not suggested for the treatment of CRE infections in UTI infections or bloodstream infections. Same as Dr. Anil was telling about use of tigecycline in blood and the UTI. The panel is against this. The same thing, the tetracycline derivatives, they achieve rapid tissue distribution following administration, resulting in limited urine and serum concentration. Though in a study I read that they had given a loading dose of 400 milligram tigecycline, followed by 200 milligram BD to achieve a serum concentration in the urine, but I don't know about the authenticity of this particular case report. Also, a limited data is available about the effectiveness of minocycline against CRE infections, but data suggests a lower proportion of CLA isolates are likely to be susceptible to minocycline compared to tigecycline or eravacycline. The panel suggests using minocycline with caution for the treatment of CRE infections. These are some debatable and contentious topics which I would like to discuss. First is the use of aminoglycosides. First of all, aminoglycosides here we all use in our ICUs. In CRE patients, we always give it a try with these antibiotics. Aminoglycosides. It was found that the microbiological cure rate was better than tigecycline for the aminoglycosides, and a combination of aminoglycoside with the tigecycline, they were better in the outcome of patients who received a non-aminoglycoside, especially in respiratory infections. There is a conditional recommendation for these things and a low, certainty of evidence for these medications. Second is fosfomycin. Fosfomycin, take it as a dictum, never use fosfomycin as a monotherapy. There are chances of resistance and we won't be able to do any benefit to the patient. Fosfomycin is always suggested in combination therapy. And studies have compared that though there are no very less iteration on fosfomycin combined studies and single fosfomycin studies, but whatever studies we have, it is non-significant and high risk survival rate of a combination therapy with fosfomycin. Extending infusion therapy, I just told in the previous slide. Carbapenem combination therapy, it was done in 2 trials, Overcome trial and IDA trial. Thank you. The carbapenem combination therapy, it suggests combination of say meropenem with colistin. There is low certainty of evidence compared to meropenem plus colistin and only colistin. Last is double carbapenem therapy. Has anyone used double carbapenem therapy? Any experience with it? How's it? Very good. Okay. Yeah. Okay. Isme, the drugs which I found in the study which were used was the rationale is any carbapenem with ertapenem. Ertapenem, it is consumed by all the Enterobacteriaceae, और उसके बाद हमारे पास दूसरा कार्बापेनम रह जाती है, which then acts in the body. So this is a rationale behind it, what the studies say, but still lot of literature has to be read on it and lot of studies have to be done on it. I haven't used a double carbapenem therapy. Thank you, Dr. Akhil, for sharing your experience. And regarding other drugs, plasmomycin, insufficient evidence, and eravacycline, study was done. There was no CR included in this. Case 5, a 40-year-old male, diabetic, impaired renal functions, previous hospitalizations, admitted with the lobar pneumonia, Klebsiella positive in blood and sputum, Piptas resistant, ertapenem resistant, meropenem resistant, PG cyclin sensitive, cholesterol intermediate, ceftazidime avibactam resistant, and aztreonam resistant. Yes, sir.
The value of doing ceftazidime avibactam and aztreonam separately. If it is a separate, it should be done as synergy test.
Yeah.
And mostly we are not doing that synergy test in most of the lab. So this is a misleading because when they're both given together, then only they will act. Then they only will act.
Yeah, totally agree with you, sir. Thank you. Thank you for your information. Thank you for the kind words. Yes. MBL, and just sir was pointing out, we go for a synergy test. This is a slide which shows a synergy test. It is individual ceftazidime avibactam and individual aztreonam, and this is the combination. You can see the disc, it is enlarged, and it is enabled to kill microorganisms more. This is known as synergy test. In my hospital also, I don't know whether they do synergy test or not, but in many labs, many hospitals, they are using synergy test and good appreciable results with this. Moving on, next case, a 45-year-old female admitted with alveolar hemorrhage secondary to vasculitis, treated with high dose of steroid and rituximab. She developed severe hypoxia with new lung infiltrate. The ET suction and blood culture grew Acinetobacter, resistant to all except colistin, meropenem MIC above 16, AMP-C and sulbactam not done. Continuing with this, what is the mechanism of resistance? What are the preferred antibiotics? This is classified as CRAB, carbapenem resistant Enterobacteria, Acinetobacter. The use of high dose ampicillin sulbactam, total daily dose of 6 to 9 gram of the sulbactam component in combination with at least one other agent is suggested for the treatment of CRAB infections. One more, not a glaring thing, but a small minuscule thing which I found out is like sulbactam, if it comes with the antibiotic, people generally, they don't give sulbactam. कई बार लगता है कि यार sulbactam तो जा ही रहा है हमारा, but that sulbactam dose which is associated with ampicillin, that is insufficient. So it is better to give sulbactam as a separate dose, total achieving 6 to 8 grams per day. Combination therapy with at least 2 active agents whenever possible is suggested for the treatment of CRAB, at least until clinical improvement is observed because of the limited clinical data supporting any single antibiotic agent. I'll just run through the slides. What is the role of ampicillin sulbactam? High dose ampicillin sulbactam is suggested as a component therapy or a combination therapy of a CRAB, regardless of whether the susceptibility has been demonstrated or not. Why? Sulbactam is a competitive irreversible beta-lactamase inhibitor that in high doses saturates plasma-binding proteins 1 and 3 of A-Bamine associates. Sulbactam unique activity against Acinetobacter isolates have been demonstrated through in vitro studies and animal models also. What is the role of tetracycline derivatives? High dose minocycline or high dose tricycline can be considered in combination with at least one other agent for the treatment of CRAB infections. The panel prefers minocycline because of its long-standing clinical experience with this agent and the availability of CLIS susceptibility. Interpretive criteria, however, tricycline is also a reasonable option. What is the role of polymyxins? Polymyxins can be considered in combination with at least one other agent for the treatment of CRAB infections. What is the role of cefiderocol? Cefiderocol should be limited to the treatment of CRAB infection, refractory to other antibiotics, or in cases where intolerance or resistance to other agents precludes their use. What is the role of extended infusion meropenem or imipenem celestine? High dose extended infusion meropenem or imipenem celestine are not suggested for the treatment of CRAB infections. Other is like, this case was reported in Pittsburgh, a patient in sepsis being treated with ceftazidime avibactam plus aztreonam combination 1 month back, which came later out with resistance. So what they found out, there is a term known as de-repression of gene. It mainly happens with ceftazidime. It is a very new topic. There is no literature, much literature available about it. What happens is with this is, if the patient is treated on ceftazidime avibactam and it comes out to be ceftazidime resistant, earlier it was suppose multi-drug resistant, even resistant to meropenem. What happens with this is, the moment it becomes ceftazidime resistance, somehow, some body mechanism, there is de-repression. What does de-repression means? It becomes now merosensitive. This is again a very new phenomena. It is being studied in USA, reported in Pittsburgh, reported in papers over there. But still, lot of work and lot of literature is required to study this particular expression. This again just a picture of it, what else the antibiotics cover with this. Sulbactam, durlobactam is mainly for OXA-23, imipenem, ceftazidime, ceftazidime, tazobactam. Again, just a flow chart, sorry, picture of what all antibiotics, novel antibiotics are in line. Ceftazidime, ceftazidime, tazobactam we are using, imipenem, verobactam, not in India, nor imipenem. I couldn't find any case report on this. I've just run through this slide. Stenotraphomonas maltophilia. It is almost like crab only. What is the general approach for treatment infections? My maltophilia, any of the two approaches. Use of following agent, trimethoprim, minocycline, or tigecycline, cefiderocol, or levoflox. The combination of ceftazidime, avibactam, and azithromycin when significant clinical instability is evident, or intolerance to activity or the agent is identified. What is the trimethoprim? Trimethoprim as a component of combination therapy, at least until clinical improvement is observed. Same with minocycline, high dose of minocycline, 200 milligrams, followed by 400 milligram, 12 hourly. Same with ceftazidime, avibactam, or fluoroquinone, or cefiderocol. This is just a slide about the intrinsic resistance mechanism of various to various antibiotics. Just a pictorial representation of that. I've just taken this slide from a novel known as Tom Clancy ki thi, The Sum of All Fears. This इसी movie बनी थी 2002 में, Ben Affleck and Morgan Freeman. So this I called it the sum of all fears, which I fear with times to come we will face this. This report I got from a leading hospital in Delhi. One of my seniors sent me this. There was a female. She was on hemodialysis. Right hand was sterile, but the right femoral HD cath, it shows Klebsiella pneumonia. You can see it is resistant to everything. Amikacin, Amox, ampicillin, aztreonam, cefepime, tazobactam, cefixime, cefoxitim, colistin, doxy, ertapenem, phospho, genta, miro, levoflox, piperacillin, tazobactam, ecipamycin, ticagrelin, everything. It is resistant to all. And you can see that at times the MIC is very high, 320, 128, 64, 256. So like, I don't know the treatment for this, but this is open for the audience. And with your clinical experience, we can share. This will be very common times to come. Because the way, like, I work in a onco setup, and to be very frank, no disrespect to the primary team or the oncologists or the oncosurgeons, but at times, sometimes things get so irrational. I'll just narrate you a small incident if there's a paucity of time. I got a patient in my ICU. He had a tumor in the trachea and he was DNI DNR. ICU में shift किया कराया, sir BP कम है, procal raised है, okay, shift in the ICU. The moment he shifted to the ICU, they changed the antibiotic from Vitran to meropenem. Okay, fine. Hypertension नहीं थी patient को, the patient was having hypertension, BP of 160, 100. Next morning, the patient had a respiratory arrest because of its mass, but DNI DNR tha, but still somehow the family wanted the patient to be intubated. Somehow intubation ho gaya. Patient not on any vasopressor support, no ADR, no NORAD, no vasopressin. The primary team comes, ceftazidime avibactam. Straight away. Rationale, sir, the patient is in ICU, patient ka CPR ho gaya, na ceftazidime avibactam. So I just told them, I got one more patient in the isolation who has a neutrophil count of just 10, 20. He's a AML patient. He's on NORAD. He's on vasopressors. He's on ADR. आप उसको भी ceftazidime avibactam दे रहे हो, इस patient को भी ceftazidime avibactam दे रहे हो. God forbid, suppose he had been a young patient और मेरे को उस patient को बचाना है. Ceftazidime avibactam के पास मैं क्या करूँगा? What antibiotic will be left with? Nothing. So this is what we are fearing. Maybe times to come, say 1 year, 2 years. And this report is from, I just tell you, is from Max Hospital, Max Saket. I got one of my seniors from there. And they're doing a case report on this. This is the only one case he has given to me, but there are many cases. It coming pan-tongue resistant, even to ceftazidime, fosomycin, everything. So this particular slide or particular antibiogram, it is open to the audience. So whatever views you have, I will be definitely highly obliged. If you can share what are the treatment options with your clinical experience and expertise, you will follow with these, if any. Thank you. Thank you very much. Maybe just, it is a food for thought also. As a clinician, what I think, we have a responsibility towards the society also. What kind of antibiotics are we using? Are we using antibiotics or are we misusing antibiotics? So this is a food for thought, just for our generations to come. हम ही बीमार हो जाए यार, हमारे पास कोई बचेगा ही नहीं कि हम किसे ठीक होंगे फिर. Thank you very much.
Thank you, Dr. Prashant. Now we'll take only 1 or 2 lecture because of the paucity of the time. If anybody wants to ask any question from Dr. Prashant.
तो मेरे को ये बता दो, मतलब मेरे लिए भी नई चीज है ये, हम क्या करेंगे इसमें? एनी सर?
If anybody wants to answer this question.
ये अभी रिसेंटली लास्ट वीक का है ये, मैंने उनसे पूछा नहीं क्या दे रहे हैं आप. यस सर.
Like we have been taught in during our PG time, like whatever we reports do in the microbiology, it's a in vitro test. So we say it is 60-40 rules. So 60% it can be correct, 40% it can be a false. So then we have to take the whatever most appropriate drugs as per the MIC value, whatever take the lesser MIC or whatever, you have to try hit and trial.
इसमें क्या करेंगे, मतलब मेरी नॉलेज के लिए?
Means like if it is a case of like Enterobacteriaceae, either I have option of Ceftazine AV or Aztreonam, or maybe the colistin, or maybe some other combination.
हमने इसमें synergy टेस्ट नहीं किया, मेरे को नहीं पता synergy टेस्ट किया नहीं किया इसमें.
But like if it is a Enterobacteriaceae, I have not seen the bacteria name. It is a
Klebsiella.
Klebsiella. Then the first I will try to Septa AV and plus Aztreonam.
Klebsiella.
Septa AV and Aztreonam will be my first choice starting in that case. If it is a colistin resistant, everything resistant, then I will try with that, start with that.
High dose of meropenem, extended infusion.
Like it is a ICMR guideline. No, actually, I just also want to suggest that like now we are following IDSA guideline and all these guidelines. Now we say that Indian data is different. But now the ICMR is coming up with every year they are coming up with the treatment guidelines for antibiotics also. And there is a guidelines from ICMR. There are 2023 guidelines also there. So we should follow also that because they are based on the Indian data, not based on the USA data.
USA or
So ICMR suggests that if it is meropenem MIC is less than 16, then still if it is a resistant also, then we can start with the extended
with extended infusion.
We can start that part also.
नहीं पता.
So
नहीं ये बताए, she was sick, she was on vasopressors, इतना पता है, बाकी I didn't inquire about it. हाँ जी सर. Okay.
Thank you.
I will end the session. Thank you very much. Thank you for being so interactive. Thank you very much.
Thank you, Dr. Prashant.
Thank you. Thank you.
So now I would like to call Dr. Akhil Taneja, next speaker. He will speak on newer antibiotics. Maybe some 1 or 2 newer antibiotics may give an option to treat these type of infections. Dr. Akhil Taneja is principal consultant in Max Super Specialty Hospital, Patparganj. He has publications in various national and international journals and chapter in books. He has a special interest in obstetric critical care, hemodynamic monitoring, ARDS ventilation, critical care sonography, and spreading critical care education. Now over to you, Dr. Akhil.
So a very good afternoon, and we are running a little late for our lunch. So I will try and hurry the lecture up so that we can have at least the lunch on time. We don't have much antibiotics left, as Dr. Prashant said, but we have a lot of lunch waiting for us. So very insightful lecture by Dr. Prashant, and ended on a very deep note that we don't have antibiotics left further to work on with. So going with that culture sensitivity report where all the drugs were resistant, my best bet probably would be a ceftazidime avibactam combination with azathionam. And if not improving, I will also add a double carbapenem for that. But these kind of drugs, they have multiple mechanism of resistance. There are carbapinemases, then there are other mechanism of resistance. So I will try and circumvent at least 2 of them with CAS-AV and azathionam combination and a double carbapenem therapy alongside. So that will be my best take for this patient. Moving forward, why do we need more or newer antibiotics? As is the right answer, Dr. Prashant has already given in the last slide. There are PDR bugs. The current antibiotics are not working. But the actual answer lies somewhere else. Actual answer is it's our birthright to use and misuse the antibiotics. And then as already existing drugs are not working, we want more of them so that we can have more CMEs, more discussions, and more lectures over them. So this is our only objective with that. This is the evolution of antimicrobial resistance. As the antibiotics are developed, the resistance is also going alongside. Linezolid launched in the early 2000s and resistance immediately thereafter. Daptomycin launched, resistance thereafter. So drug resistance follows the drug like a faithful shadow. Now that is the reason we are looking for newer antibiotics. So these are the WHO priority list for the drugs. They say priority one are the critical one, that is carbapenem resistant Acinetobacter baumannii crab, carbapenem resistant Pseudomonas aeruginosa CRPA, carbapenem resistant Enterobacteriaceae CRE. Now these are the priority or critical priority organisms. Then there are high priority organisms like Enterococcus faecium and vancomycin resistant Staph aureus, which is MRSA or can be a VRSA. Now these are the 5 common bugs we are dealing with. These 3 gram negative and 1 gram positive, that is MRSA. These 5 are leading cause of mortality worldwide. In the Indian scenario, this is the data by ICMR in 2021. E. coli followed by Klebsiella, Acinetobacter, Pseudomonas, and Staph aureus, then Enterococcus. So we have more of gram negative, less of gram positive, but then top 5 are these only. This is the projection by 2050 that antimicrobial resistance will be the most common cause of major death worldwide. So what do we have? We have newer agents which are approved by regulatory authorities, available in Western countries, most of them. Few are available with us in India. They are used for patient care in real world. Some are and other may be soon available in our country, and they are used against the MDR bugs. So we are talking here only about the MDR bugs. Cephalosporins, now these are older drugs, class 1, class 2, 3, 4, and then the 5th one. The class 1, primarily they were gram-positive agents. As we moved from 1st generation to the 3rd generation, they became more of gram-negative. Class 4 or 4th generation, they are only gram-negative. Now this is the newer class, the 5th one, the ceftobiprole, ceftaroline, and ceftolozane. Now these are the 5th generation cephalosporins. Now they are mostly having a gram-positive action, except one. So coming to newer drugs, this is the list of newer drugs: ervacycline, plazomicin, delafloxacin, levonadifloxacin. Now these are single agents, the newer drugs of older classes. Ervacycline from tetracycline, plazomicin is an aminoglycoside, delafloxacin is a fluoroquinolone, then levonadifloxacin, it is again a fluoroquinolone. Then there can be a newer beta-lactamase inhibitor with old beta-lactam, like vaborbactam is a newer BLI. Relivectam is a newer BLI, and then avibactam we are commonly using. Then there can be 5th generation cephalosporins, the ceftolozane with tazobactam, cefderichol, and ceftaroline. Now this is the newer generation of drugs. Now we can classify them in some other way. Levonadifloxacin and ceftaroline, these are gram-positive agents. All other are gram-negative agents. Moving forward, those they are in deep green, they are available in India. Plazomicin will be soon available in India by mid of this year, probably. Cipla is launching it. Other drugs are still not available in India and not even in the pipeline to be launched over here in our country. So I'll just focus on those which are probably available with us for use, and let's have a brief review about them. Moving to the first drug, the ceftazidime-avibactam combination. Ceftazidime is the older drug. Avibactam is a newer beta-lactamase inhibitor. Now, FDA has given approval in 2015 and extended to VAP in 2018. Dose is 2.5 gram size daily, where 2 gram is ceftazidime and 0.5 gram is avibactam. So we have seen this Ambler's classification a lot of times since morning. So what is very special about it? The special thing is that class B stands apart. Class B are metallo-beta-lactamases, where we have the NDM, VIM, and the IMP. Now, most of the drugs which work on serine beta-lactamases, that is class A, C, and D, will not work on class B. That is the differentiation here. With ceftazidime avibactam, it will work on class A, class C, and class D. So for that matter, if you are having a report of KPC carbapenemase, if you have a report of OXA48 carbapenemase, we do not need any synergistic combinations. We need only ceftazidime avibactam. But with NDM, this drug is not going to act. That is the problem here. That is why we add azathionam for the synergistic action. The point is that azathionam is not hydrolyzed by NDM, but it is hydrolyzed by class A, C, and D. So giving a combination of ceftazidime azathionam along with azathionam, we are circumventing this pathway. Azathionam will act on NDM and ceftazidime avibactam will act on all the other enzymes. And with NDM, there is almost always a co-production of OXA48 and probably KPC somehow. CTXM is almost always there with NDM. So it cannot alone be a NDM producing carbapenem resistant bug. It will always be a NDM producing carbapenem resistant bug along with some co-production of OXA48 or CTXM. So we need ceftazidime avibactam for the enzymes on the left side and azathionam on the right side. So this is how it works, the combination. So this is all about the summary. Ceftazidime avibactam along with azathionam, where to give, where not to give. E. coli, probably yes. They say about 70 to 80% of Klebsiella strains in India, they are sensitive to this combination, whereas about 50 to 60% of E. coli strains, they are sensitive to this combination. So E. coli, probably yes. Klebsiella, definitely yes. Pseudomonas aeruginosa. Now, Pseudomonas aeruginosa has multiple resistance mechanism other than the carbapenimases. So where this combination will never work. So do not use ceftazidime avibactam with azathionam combination for Pseudomonas aeruginosa. It is not to be used. Acinetobacter, definitely no. There is no role over here. So Klebsiella, definitely yes. E. coli, probable yes. All other two, no role. Gram positive, no activity. So it is for carbapenem resistant, Klebsiella and E. coli probably. So I move forward. The second one is cifdericol. Now this is a new wonder agent, they say. This got a very novel mechanism of action and a very novel coverage. It was approved in 2019 and further extended to HAP and VAP in 2020. So it is working against Acinetobomani, Stenotrophomonas maltophilia, NDM producing Klebsiella pneumoniae. So all of the common MDR works, it is working. Dose is 2 grams thrice a day. Now, this is a very funny picture. Now, this is what they call as Trojan horse strategy. So mechanism of action is Trojan horse strategy. What they are doing here is they encapsulate the antibiotic along with a carrier. That carrier is taken into the bacterial cell and the drug is released. So this is why it is called as a siderophore antibiotic. Now, what is happening here is it binds to the iron. There are iron transport channel in the bacterial cell wall. The iron transport channel transports the complex of iron with antibiotic into the cell and where it dissociates and does it action. What is the spectrum? This comes with a name of Petroja. Trade name is Petroja and now it is available in India. It is being imported. So you can definitely arrange for it. The cost somewhere lies between 4 lakh to 5 lakh for 10 vials. But the dose is OD, so it can be done for 10 days with that much of cost. Again, it's a costly affair, but then let's have a look at the coverage. Enterobacteriaceae, ESBLs covered, AMC covered, serine carbapenimases covered, NDM covered. So this is where the wonder lies. Klebsiella covered, E. coli, MCR1, colistin resistance covered. So that's where the answer for your question lies, Dr. Prashant. Colistin resistance. Probably this is the drug we are looking forward to. Pseudomonas aeruginosa, all enzymes covered. Acinetobacter baumannii covered. Stenotrophomonas maltophilia covered. So all 4 common MDR gram-negative bugs, they are being covered by this single agent. So that's why they are looking at this agent as a wonder drug. Now, whether it will be a wonder drug in clinical practice in India is something to be answered later on. As we have a propensity to overuse and misuse, we probably generate resistance much faster than the Western world. So that's where the point is. Because of some unknown reasons, not cited, the FDA has given a black box warning over here, that FDA label warning for higher all-cause mortality versus other antibiotics in critically ill patients with multi-drug resistant gram-negative bacterial infections. So with this warning, probably this drug to be used in only those patients where other drugs are not working or are having resistance. So to be kept as a reserve drug. Probably they want to keep it as a reserve drugs. That's why given this warning. Next is ciftaroline. Now this is a gram-positive agent. As discussed, is a 5th generation cephalosporin, primarily eliminated by kidney. Required dose reduction in renal impairment. Dose is 600 milligram 12th hourly for both skin and structural tissue infections and community-acquired bacterial pneumonia. This is a very strange statement or paper. They came in 2014 on 15. They say even if a gram-positive bug or MRSA is resistant to daptomycin, you give a combination of daptomycin with ciftaroline, because in presence of ciftaroline, daptomycin sensitivity is restored. So for MRSA, as of now, as per recent literature, we'll just be focusing on the center pink part. The priority combination is daptomycin with ceftaroline, not the vancomycin. It is at the priority 3 because vancomycin these days is not a preferred agent in critically ill patient. I'm not talking about those patients in wards or in OPD. I'm talking about those patients who are admitted to ICU with septicemia or sepsis or septic shock. That's where vancomycin doesn't score over the other drugs, and the preferred combination is daptomycin with ceftaroline. So next is levonorephoxacin. Now this is one drug which is indigenous. It is made in India drug, derived in India. It is a synthetic drug commonly used nowadays, probably in all the parts of India. It is levonorephoxacin, which is a prodrug a la levonorephoxacin, novel broad spectrum anti-MRSA agent. Other fluoroquinolones, they act on topoisomerase. Now this has preferential action on DNA gyrase. Coverage is positive, negative, atypical, and anaerobics. There is no dose adjustment which is required for renal or hepatic impairment. So gram-positive pathogens, MRSA, VRE, Visa, linezolid resistant Staph aureus, they are probably covered. Few gram-negative pathogens, not for the MDR gram-negatives, but general gram-negatives are covered. Atypicals are covered and anaerobes are also covered. So one drug covering, having a very broad spectrum actually. As compared to other drugs, what are the benefits? So when we are comparing these benefits, we will be comparing to the only gram-positive agents. First, it is both IV and oral availability. Bacterial killing is very potent. It is a bactericidal drugs. Now, MIC to breakpoint ratio is very less. Now, this is something which we need to understand. As MIC is far away from breakpoint, this drug will be a more potential agent than compared to other agent. If you get a sensitivity report with all these 5 drugs with this MIC to breakpoint ratio, as the MIC is reaching breakpoint in all other drugs, there will be more chances of treatment failure. As MIC is very less than the breakpoint in levonorephoxacin, the chances of treatment success will be more. Lung concentration is excellent. They say that the epithelial lining concentration is 7 times more than serum. So it is concentrated in lung. Although it has not got approval for pneumonia or VAP, they are still trying for it, but then probably seems to be a good drug for that. Gram-negative coverage partial, anaerobic coverage is there. And then finally, there is no dose adjustment for renal and hepatic impairment. Indications are acute bacterial skin and structural tissue infections, diabetic foot infections, and concurrent bacteremia. Dosage is 800 mg IV 12th hourly. With tablet, it is 1000 milligram. Contraindication again is hypersensitivity to any of the quinolones, history of tendon disorders, and then children or growing adolescent, they are contraindicated. So, last one is plazomicin. Now, this is aminoglycoside. It is soon to be launched in India, probably by May or June, as have been told by the manufacturers. So, synthetic aminoglycosides, dose-dependent bactericidal activity is there. Dose is 15 mg per kg once a day. Nephrotoxicity and ototoxicity are the common side effect. Now, the advantage with plazomicin over other aminoglycosides is like we have carbapinemases for carbapenem, we have aminoglycoside modifying enzymes for the aminoglycoside. So it blocks most of these enzymes. So where other aminoglycosides are not working, probably this may be working. Maybe. Clinical course, again, we have to see. So dose is 15 mg per kg per day. There were 2 studies that compared it with the carbapenem and levofloxacin, and they found it to be non-inferior actually. So in this study, only a limited number of patients were included with CRE, but they found it non-inferior to meropenem and levofloxacin, and it is to be launched soon enough. Other 3 drugs which I will be discussing in short are those which are not available with us in India. So I've gone through with, them in a short period. Ceftolozane tazobactam is a combination of modified cephalosporin with tazobactam, stable against multiple resistant mechanisms, including overexpression of AMC, porin loss, or drug efflux pump. Dose is 2 gram IV 8th hourly. Good data available with more than 40 studies and got a better safety profile than other drugs in AKI. But the problem again is Pseudomonas aeruginosa. When we say this statement that best beta-lactam activity against Pseudomonas aeruginosa among cephalosporins, now this is very important for those Pseudomonas aeruginosa which are sensitive to cephalosporin, not producing NDM, not producing carbapenemases. this can be a good drug. So now all this data comes from Western world where NDM is not a major problem. So that's why they give treatments like this. So other is meropenem varorbactam. Varorbactam is the new beta-lactamase inhibitor derived from boric acid. It protects meropenem from degradation by class A and C beta-lactamases. Now problem again is not against B and D, which are common in India. So A and C common in Western world. They are happy with this drug. B and D, it is not working. We are having a problem of B and D. Probably we will never be happy with these kind of drugs. Last is imipenem relibactam. Same problem again, not working against class B and D, which is a problem with us. So last is ervacycline. Now, this is for Acinetobacter baumannii. They launched it, but then no activity against Pseudomonas aeruginosa. Even with MDR Acinetobacter, the results have not been very encouraging. So not much which I should propagate. This is to summarize all the beta-lactamase inhibitors, the avibactam, tazobactam, vaborbactam, and relibactam. Best among them, which we are using as of now, is avibactam, which is active against all bacteria, all beta-lactamase enzymes other than metallo-beta-lactamase. For metallo-beta-lactamase, we add azathionam as a synergistic action. Cifdericol seems to be working against all. So this again could be a potential answer to our MDR and PDR bugs. That's all. Thank you. Thank you very much.
Thank you, Dr. Akhil, for this wonderful lecture. I hope that some of the antibiotics which is not available now in India will be available in couple of years. And because of paucity of time, we can only allow a few questions from the audience, one or two maybe, and then we can end the session and proceed for lunch.
Theoretically,
sir,
thinking
for that, there is something else to be considered. Is iron deficiency affecting the bacteria? Bacteria mostly have an iron co-transporter. There will be definitely be iron which will be transported from outside to inside and then from inside to outside also. So that transportation will always go on. Whatever available iron is there, the antibiotic is going to bind to it and then transport it inside the bacteria. Our main aim is to transport the antibiotic inside the bacteria, or what I can call is to circumvent a resistance mechanism of pore channels actually. So now again, Sidro-4 antibiotics are one option for that. Other options are being also developed. But then definitely I cannot very much comment on this talk, whether iron deficiency will affect the efficacy or not. Because I have personally not used these antibiotics. These are newer ones. Mostly I have not used. I have read only, so I'm taking a talk. So I have no experience with cifdericol, and per se I cannot answer this question also. But theoretically, it should not affect. Yes. Sir, these days there is a concept of adjuvant therapy for antibiotic. People are giving EDTA pre-filled syringe as an adjuvant therapy. Probably we'll have some iron supplement pre-filled syringe for supplement therapy with cifdericol as well. So we sulbactam is an adjuvant therapy, EDTA is an adjuvant therapy. We will have iron pre-filled syringes to be given with cifdericol as well. We can have that, sir, in India. Definitely, sir. 4 to 5 lakh for 10 vials. 4 lakhs for 10 vials. OD dosing, 40,000 per day. So if you are using it as a mono agent, it is not actually very costly. You give polymyxin along with Zevicepta, azathionam, along with meropenem, along with micafungin, it is 70,000 per day in a corporate hospital. So 40,000 per day therapy is not very much actually. Comparability in relativity.
Time will tell whether it will change the game or we will change the drug.
That is to be seen, sir. That is the worry. Then we can have more CMEs and you can be more, you can have, you can be chairperson more times. I will take more lectures. We'll just change the drug. Try to put the bacteria
Before you people like, oh, इतना सारा microbiome पढ़ना पड़ेगा या फिर microbiologist को ICU में बुलाना पड़ेगा. At least you have given us something, we can start with that. So we don't need much of those knowledge about
Thank you, ma'am.
Thank you.
Thank you.
Thank you so much, Dr. Akhil Taneja, for giving us update on our newer antibiotics. Now, to felicitate our speakers, I request Chairperson Dr. Manju Tyagi, Dr. Ashutosh Garg, Dr. Devshankar to present a memento to our speakers. Dr. Prashant Singh on the stage, please. He's a senior consultant, CCM, Rajiv Gandhi Cancer Institute, New Delhi. We welcome you, sir. A huge round of applause, everyone, for Dr. Prashant Singh. So I would like to invite our next speaker, Dr. Akhil Taneja, on the stage, please. Please join. A huge round of applause for Dr. Akhil Taneja. He is a principal consultant, CCM, Max Hospital, Patparganj, New Delhi. Now, to felicitate our chairperson, I would like to invite Dr. G.C. Vaishnav, sir, to please come on stage to felicitate Dr. Manju Tyagi. Please join us, ma'am. A huge round of applause for Dr. Manju Tyagi and Dr. Vaishnav, everyone. Thank you, sir. Thank you, ma'am. Now I'll invite Dr. Parul Isar to join on stage to felicitate Dr. Ashutosh Garg. He's a senior consultant and head CCM Kailash Deepak Hospital, New Delhi. A huge round of applause for Dr. Ashutosh Garg, everyone. Audience. Thank you, sir. Thank you so much, ma'am, for joining us. Now, to felicitate Dr. Devshankar, I would like to invite Dr. Prashant from PICU, Yatharth Noida Extension, to come on stage to felicitate Dr. Devshankar. He's a senior consultant, CCM, Fortis Hospital, Vasant Kunj, New Delhi. Thank you so much, sir, for taking out time and joining us today. A huge round of applause for the chairpersons and the speakers, everybody. With this, we are concluding our morning session. Now, I would like to invite all of you for a lunch. We'll meet sharply at 3:30 after the lunch for our next session, for the evening session. Thank you so much. Please be with us.
Thank you, Dr. Vaishali. Template. Welcome back post-lunch session. So we are going to start with the panel discussion. So that is our session number 3 in the last session. So we are going to discuss infection prevention control in this first panel discussion. So for this, I would like to invite my panelists first. So I'll just like to invite Dr. Rajiv Gupta, sir. So he's the additional director and head pulmonology and critical care and sleep medicine at Fortis Hospital, Greater Noida. Sir has been a teacher and then he's been practicing for last 2 decades. Experience has got widened in the respiratory disease, various diagnostic and therapeutic procedure, bronchoscopy, EBUS, TBNA, and whatnot. So he's a critical care specialist with expertise in management of critical care condition like septic shock, multi-organ failure, ERDS. He's got a number of publications, numerous national and international scientific publications. Welcome, sir. Next panelist is Dr. Amit Agrawal. Dr. Amit Agrawal is a senior consultant head microbiology, and he's a dynamic person who has recently joined our organization. Welcome, Dr. Amit Agrawal. Then we have Dr. Neha Jain. She's a consultant microbiology and infection control officer at Yatharth Super Specialty Hospital, Noida 110. And she's got various publications in national and international journal. And she's got a special interest in virology, transplant infection, and antimicrobial stewardship. Welcome, Dr. Neha. And we have got our 4th panelist as Ms. Shinu Varghese. She is a chief nursing officer over in the maximum number of applause come to you, Dr. Ms. Shinu Varghese. So she's got more than 26 years of experience. She's an NABH assessor and principal assessor. She's a ISO internal assessor and worked in collaboration with Ministry of Health and Family Welfare. Welcome to all the panelists. So when we talk about infection prevention and control, so the first question which comes at the back of our mind, what exactly is the infection prevention and control? So what exactly is the reason? Why do we need it? What is the requirement for infection prevention and control? So right. So infection prevention control and quality standards of healthcare are essential for well-being and safety of the patient, their families, health workers, and for the community. So as we all know that hospital-acquired infection, which is the most dreaded and the most feared, issues or events in the healthcare sector, the most common adverse event during the healthcare delivery and major public health issues affecting the morbidity and mortality of the patient. HAs are largely preventable through effective infection prevention control. So that is the reason why we require the infection prevention control. When was it when we had thought of infection prevention control? So that was way back in 1950s. So almost 70 years back when we had seen that. So it's been seen that infection prevention and IPC quality standards of healthcare are essential for. So next slide. So in the United States, the hospital discipline of infection control was established in 1950s, which we was talking about because there was a spread of Staphylococcus aureus epidemic as a nosocomial infection. And then they've seen the nosocomial infection surveillance that it was this bug which has led to the epidemic. And when they had curtailed this bug by doing some practices, then they found that, yes, this is the therapeutic, not therapeutic, rather a preventive measure which can be used, and perhaps we can curtail the infection in the healthcare setting.
Then they did a study wherein this infection control project was done with the name of scenic study on the efficacy of nosocomial infection control, which has shown a strong evidence that effective IC programs with specific surveillance reporting and staffing component could demonstrate a decrease in the hospital-acquired infections. So with this background, we'll just move on to a case because we'll just want to make it more relevant how the infection prevention control practices could be helpful when actually we are dealing in the healthcare setup. So this is a case wherein a 60-year-old next 60-year-old female, known case of diabetes, hypertension, post-renal transplant, which was done 6 months back, has on receiving, of course, immunosuppression, has presented to the hospital with mild to moderate grade fever, generalized body ache, and then she started to have cough for last 2 days as well. She was also feeling breathless, and that was the reason why the family brought the patient to the hospital. And because we are living in the post-COVID era, and then of course the patient was immunosuppressed, so we took the history whether the patient has received any COVID vaccine or not. So she did receive 2 vaccines of COVID. She has not received any booster thereafter. So when the patient presented in the ER, she has a GCS of 12 to 13. She was tachypneic, she was febrile, she was tachycardic, and then when the pressure was taken, she was having low blood pressure, which responded to fluid treatment. On auscultation in the chest, she has bilateral air entry, which was equal, but she had some basal crepes. ABG was suggestive of metabolic acidosis, respiratory acidosis. I'm so sorry, it's metabolic acidosis with a lactate of 4.4. She has a sugar of 188 mg/%, and then straightaway she was started on meropenem and teicoplanin. The X-ray which was done in the triage was looks like this. So the patient was with this background, with this basic antibiotic, with this X-ray, the patient was shifted to the ICU because she was having a requirement of oxygen, which was escalating. So we had started her on non-invasive mechanical ventilation. Some investigation which were sent from the triage, the investigation reports are there. The TLCR on the lower side, 2100, and then with a procal of 0.8. All cultures were sent, rest investigation were within normal limits. So the patient was managed with the respiratory therapy in the form of non-invasive ventilation. She is a post-transplant patient. She's on immunosuppression. She's having breathing issues. And then X-ray looks bad. And she's got some complaints which were there in the, on auscultation. So my question to the panelists would be to Dr. Amit Agarwal, what IPC strategy shall be acquired in this patient? Hello.
Actually, if we see, this is a case of post-transplant infection, and most probably it's a LRTI. So generally, when we talk about the post-transplant, generally we keep patient in isolation in positive pressure room to prevent the other infection. But however, here it is like LRTI is there. So if we see that is 6 months post, so generally it is if it's a renal transplant patient after 6 months, generally the community acquired infection is most common LRTI. If you talk about the bacterial, so like Streptococcus, H. influenza, Mycoplasma is more common. So, and the second is viral infection can also be there. So until we don't know exact mechanism, like that they have a different or it can be TB also in India common, so we cannot rule out that also. So the actual strategy depends on what type of bacteria once we get the culture report or the any PCR report there. But at the first, we should isolate the patient in a positive pressure room, isolate, so that it does not get any further infection. So we can prevent it from any further infection. And then based on the other, whatever culture reports are sent comes, then we take the next step as per the transmission-based precaution, whether it is contact or with droplet required or whether it is required airborne precautions. So that will be my strategy.
Right. So as aptly mentioned by Dr. Amit Agarwal, so he's going to look further, further workup, further culture, further reports, and then he's going to isolate the patient in the isolation room, which is having a positive pressure. Of course, we'll come to that part as well. That is a transmission-based precaution. But of course, for transmission-based precaution, we have to learn the standard precaution. So we have to, take care of the standard precaution for every patient. So we'll just start with the basic first. So when we talk about the standard precaution, so this is a standard precaution which is used for all the patients which are there in the hospital and primarily in the ICU. So standard precautions. So if I ask Dr. Neha, please, can you please elaborate on the standard precaution?
So among the infection control practices, standard precautions applies to all the patients who come to the to hospital. Actually, hospital gets a burden of all the disease patients in the community. So that is why it is at a very high risk of transmitting infection from one patient to another and patient to the healthcare worker also. So regarding this, we have PPE, which was advised by OSHA guidelines also. We say when in any job there is a risk to the worker, you have to apply adequate PPE. Now, PPE depends on the kind of the job description the patient has. Like if in suppose in the lab, all the samples have to be taken and considered as potentially infectious. So you have to handle all samples with using minimum gloves. Apart from this, like cap, gowns, and particularly in OTs, where the contact time with the patient is too much, then you have to apply for full PPE. And that is why we use gowns, we use shoe covers, head cover, and everything which is possible, because the contact time with the open patient is too much. And apart from standard precautions, we have contact precautions, airborne droplet precautions, which is particularly mainly for respiratory cases, which we apply, like we have witnessed, in fact, seen the history of the COVID, where we have definitely felt the need and we have realized how much it has been important to prevent cross transmission.
Right, ma'am. So we'll come to that part as well. So when we talk about standard precautions, so these are the, as you aptly mentioned, though, so these are the precautions which should be taken for all the patients who are admitted in the hospital. So when we talk about standard precautions, so these are the key components of the standard precaution. So hand hygiene, PP, as you rightly mentioned. So respiratory etiquettes, cough etiquettes, prevention of injuries from sharp, environmental control. When we talk about the hand hygiene, which is mostly stressed in all the hospital, in all the talks, in all the infection prevention control guidance, antimicrobial stewardship, this or that. If we talk about hospital, we talk about hand hygiene. So I'll ask Dr. Ms. Shinu Varghese. So what is the what is the just first about hand hygiene? What exactly is the relevance of doing hand hygiene, and how do we do it?
Hand hygiene is something which breaks the chain of infection. If you do it religiously, within from heart, for each and every patient, when you're going, you're touching. WHO has given 5 moments of hand hygiene. If you're religiously doing and following those 5 moments, I'm sure we'll break the chain of infection. Because wherever you're touching, even the surroundings, you're touching the bedside railings of the patient, IV stand of the patient. And then if you're not doing the hand hygiene, you're carrying the germs to other subordinates or your colleagues, even at home. So the significance of hand hygiene is very, very important. And if I see before COVID, the hand hygiene compliance as an NMH assessor, when I was going to the hospitals, the hand hygiene compliance was only 65 to 70%. And during COVID, it went up to 98 to 100%. Now, if you see, it has again come down. So people have lost that interest of doing the hand hygiene and they have stopped it. So I would, with this coming up, I think, Dr. Amit Goel, I thank you that you've given the opportunity to speak over here and take this opportunity to make the awareness of creating the hand hygiene project again and wash the hands rigorously so that the germs and the microorganisms are not carried and transferred to other patients, and we break the chain of infection.
As very rightly said, ma'am. So hand hygiene is the one modality, one process, one the measure which we can use or acquire in standard precaution, or for every precaution which has shown to decrease the mortality as well. So as you mentioned, that 5 moments of hand hygiene, and this is what the WHO and CDC also regularly press upon, that hand hygiene, wash your hands should be done regularly. So these are the steps for hand washing. So as we all know, so we all have seen in our hospital, in our working place, that this poster is being pasted on, but unluckily we do not follow all the 11 movements of the movement which should be done for hand wash or for hand rubbing. So I would again urge to all my colleagues and friends that we shall start doing and then using all those 7-8 movements which should be done for hand rub, and then if the hands are visibly dirty, we shall not go for hand rub, we shall rather go for hand wash. As Dr. Neha has mentioned about the PPE, so there is one important component of PPE, which is mask. So when we talk about PPE, so we always stress on that aerosol generating procedure. So I'd like to ask Sir, Rajesh Sir, so what are these aerosol generating procedure, and then what is the relevance of mask, especially when we talk about PPE?
See, any procedure in which the health worker is in close contact with the respiratory secretions of the patient, that will be requiring an airborne precaution to prevent the spread of disease from the patient to the healthcare worker. So in that, what all procedures like simple nebulization, or when the patient is coughing, that generates a lot of aerosol. Simple procedures like nebulization, which has been talked about a lot during COVID, or doing in intubated patients doing the tracheal suction, open suction rather than using a closed suction, bag and mask ventilation, and the procedure of intubation, again, which was also talked a lot about during COVID, doing a procedure like bronchoscopy or chest physiotherapy, all these they make the patient cough or inducing cough for collecting samples. So these are all aerosol generating procedures, or doing bronchoscopy or applying non-invasive ventilation. They all are aerosol generating procedures. So to prevent exposure to all these aerosols, the health worker is advised to use a mask. So in all the situations, these are important when you are coming in close contact to the patient. So at least a surgical mask should be used, or in very highly infectious diseases like COVID or tuberculosis or similar problems, N95 mask is preferable. So that way the airborne precautions between the healthcare worker and the patient. And there are certain steps we have to take to prevent the spread from one patient to another. And that would need the standard precautions like hand wash, and also some ICU setup, the engineering part of it, so that there is at least 12 air changes every hour in the
Absolutely.
ICU.
So there's these group of patients wherein we suspect high risk of aerosol transmission. So these group of patients shall be kept in the negative isolation areas, wherein we are doing an aerosol generating procedure, and then the healthcare worker shall wear a N95 mask, and then those who are assisting him also should wear a N95 mask. And yes, of course, engineering is required in that room, wherein a negative isolation should be maintained, and then this is what the aerosol precaution or isolation room would be. Right, I'll come to that part again. So I'll just talk about the cough etiquette. So just, as I mentioned, sir, about the cough etiquette. So what is this cough etiquette? I'll just ask Shinu ma'am, what exactly is the cough etiquette, sir?
So cough etiquette is to prevent the respiratory infection we need to prevent. And that needs to be taken care by normal people also, and the patient also. So if you feel like having cough or sneezing, always use a tissue paper or a handkerchief and throw it immediately after use. Or always remember, when you're coughing or sneezing, you have to turn away from the people wherever you are standing, even if it is in a crowd, or you're talking with people, or turn your face away. That's very important. Or else the germs and the microorganisms will be generated, and it will be affecting the people who are nearby. And if it's a patient, you always encourage the patient to wear a mask, so that the mask can be discarded once the patient is either coughing or sneezing. And this needs to be educated to everybody, even the your colleagues and your patients also.
Right. Thank you, ma'am.
I think the cough etiquette should be a part of school teaching.
Okay.
So right from the school, जैसे बच्चों को टेबल मैनर्स या बातचीत करना सिखाया जाता है, so cough etiquette should be taught right from school.
Precisely, sir. Very precisely said, sir. Because it's not only the hospital, which is the area wherein we shall emphasize on cough etiquettes, should be started from home, from school. Right. So coming back to the PP part again, so what all other components of PP, as Dr. Nia has mentioned? So you mentioned about the respiratory part. So we've just discussed about the aerosol generating procedure and then the cough etiquettes, gloves, and then you've talked about the gowns and then this overall cover gown. So, I mean, what are those procedures wherein you would recommend a clean gloves or sterile gloves or clean gown or sterile gown?
So in procedures like high risk areas like OT, when we are inside the patient is open, definitely nothing will work except sterile gloves. Apart from this, some semi-risk or semi-critical areas like transporting the patient or in endoscopy, suppose if you are not directly relating to, like it is semi-critical device, you are not into the lumen of the patient, actually a skin and soft tissue only you're touching. You can still work with non-sterile gloves, but gloves, because the healthcare worker may himself have some injury. So there are many chances of transmitting from the worker to the patient also. It is not just about the patient to the worker. Then in labs, definitely nothing except gloves. Gloves may be better. It can be reused also. I mean, like if you can sanitize it again and you can reuse it, actually should not be reused. But in case, I mean, till you find the next new gloves, I think you can still reuse it is better than using, I mean, your own same glove you can reuse, better than finding a new one.
Sir, anything about the shoes, sir? Amit, sir, Dr. Amit Agarwal. Shoe covers. So we talk about whether ICU should use shoe cover or we shall not use shoe cover in the ICUs.
It's a very controversial topic, and there is pros and cons. Everybody says, somebody says we should use, somebody says we should not use. In Western countries, now it is discontinued. What are the places? But again, it's my personal opinion. Like we can't copy everything what is mentioned in the Western countries, because there is the surrounding, the environment is totally different what we found in India. Like there is total dust free, clean and everything. So if you're coming into that, but it is okay. But if you come to India, if we go outside and we see the surrounding, that now our Yatharth hospital, if you're coming outside and then your shoes are already. So again, it's a, and there is no study actually in India per se, because but my opinion, it can be used, but it is up to the management or the maybe the infection control team or the ICU team if they decide. There's no clear cut.
So that's a microbiologist perspective. I'll just need an intensive perspective as well.
So on ground, right? See the real life experience of, providing shoe covers is not a cheap affair. And who bears the cost, right? So the problem here is, we may debate whether to use shoe covers or not to use shoe covers. There have been studies. Unfortunately, there is only a couple of studies, one from Pune, FMC Pune, and one from Pakistan. So, which they found that the use of shoe covers, right? So it is taking what is on your shoe into your hands.
Right, sir.
And with that, the patient family member goes and touches the patient. So if you are not wearing a shoe cover, it would have remained on your foot. Now it's on your hands. So hospitals cut corners in providing good shoe covers, and then it becomes a bigger problem. So there are a number of factors to it. So some hospitals use it as a deterrent for number of attendants to enter in the ICU. So, but if we speak about the science of it, maybe it's counterintuitive, because once someone is putting on the shoe covers, you are touching your shoes, uske baad hand hygiene ho rahi hai ki nahi ho rahi hai. If you do a proper hand hygiene, whether you
that is the most important thing, sir.
Yeah.
The hand hygiene to shayad wo karte hain, lekin but they are not doing it properly.
Yes.
They're not following all the steps.
Proper hand hygiene is done, whether you put on shoe covers or not, it doesn't matter.
Right.
One more thing which I wanted to say was,
Not an issue. Not an issue, sir. Yeah. Please.
I totally agree with Dr. Rajesh, and what I have studied during my ICN course and all is that when you're walking, the particles are not going above your knee length. It is only on your surface area. So we are not actually supposed to use these shoe covers or remove these shoes. Like sir said, we are touching the hands with the hands, and the hands are getting contaminated. After hands getting contaminated, we are not doing the hand washing. It is only hand rub which has been used. So the dirt which is coming on your hand is not going to get removed with the hand rub. It will only go with hand wash.
And that perhaps is the same concern which Dr. Amit Agarwal is having, this the dust or the dirt which we are taking into our ICUs, and then in the resource limiting area, like in our country, our ICUs, wherein we are not getting the regular mopping, regular cleaning. Perhaps that dirt may settle onto the patient's bed and then maybe surrounding.
Absolutely.
And that is perhaps the concern what Dr. Amit Agarwal want to emphasize on.
That's true, but the concept which sir said was.
A very simple solution to this would be that the ICU mopping is done after the visiting hours. So that timing has to be done. But most of the places, the housekeeping staff is in a particular shift and they won't heed to. The system will not align in that way कि morning or evening shift के बाद जब भी visit होती है उसके बाद पूरा आपका ICU floor wet mopping की जाए.
Actually, it is like that. CDC recommends every 2 hourly in critical areas you should do mopping. If we follow that, then it's okay. Whether we wear it or not.
Sir, it's not happening twice a day, sir. Too early, so it's not possible. 12 times a day.
Twice or thrice, that is the issue. But everything has to be seen. It is not a very straightforward question. It has to be taken into consideration every factors, like whether we are doing hand hygiene or not, whether we are doing mopping or cleaning properly or with proper chemical. So all this, if we are following other things, then maybe shoe cover is not required.
I have seen a solution to this. I mean, perhaps Dr. Rajat Agarwal may enlighten on that part. I mean, in the ICU of Fortis Hospital, just outside that ICU, there was a sticking, sticky mat was there, which used to perhaps take off the dirt of the, visitors who are used to enter the ICU. Right. So washable and reusable. I mean, they used to go to the from fresh shoes to wash shoes and then or the discarded shoes. They used to come back to the fresh shoe. Yep, they never used to get washed. Yep. Right. So, please.
I will like, share my experience at my hospital, the Dharamshala Narayana Super Speciality Hospital. When I joined there 6-7 years back, there was huge consumption of PPEs, including shoe covers. I had to be, really, I had to turn the tide, and it took me a lot of efforts. The infection control team, people at the helm, management people, they were not keen to remove shoe covers. We had to do an audit, a 3 months audit we had to do, and then we had to prove that the shoe covers are not of any use. And then, they agreed to remove the shoe covers through infection control committee meeting. And that was minuted.
Sir, any comment from Dr. Ranji Chatterjee?
Completely different perspective from a government hospital, because you deal with patients, patient relatives who are not be compared with our patient relatives. We have that sticky one in front of my ICU that works very well. So I thought, why not to bring something where you enter your leg and a shoe cover will automatically come and you'll take it out. There are machines like that. We started that in 2007-8. एक आदमी का पैर ही फंस गया उसके अंदर. उसके बाद तो निकालना ही मुश्किल है, उसको डिस्कार्ड हो गया. उसके बाद क्या हुआ कि प्लास्टिक शू कवर्स आने लगे. प्लास्टिक शू कवर आ तो गया, but where to dispose them? Once they comes out, they throw it here and there, though there is shoe cover area. So it was creating a lot of nuisance. So now our policy is that sticky pad and enter with your shoes. rather than using shoe covers, and especially washing that shoe cover, what you are telling, that washing is another nuisance.
Cloth one, yeah.
You don't know which one is washed one and which one is not washed one. एक रहता है washed, एक रहता है used. लोग आके wash वाले से उठाया, फिर used वाले को wash वाले में डाल दिया. Now you don't know. So everything is, especially about the UK part that you were telling about the Western countries, when we all have been, might be there. I didn't polish my shoes for 3 months there. It is so clean. See, just situation outside your hospital, what is going to happen? So, so the perspective is completely different.
So that's what I'm saying. Like, we cannot use the shoe cover, but then we have to improve our the housekeeping moppings and the hand hygiene practices. We have to improve.
Agree.
That is the answer.
Only one thing which I could decipher, the positive effect of imposition of shoe covers and PPs in the areas where the attendants are little arrogant. So it acts as a deterrent. ये पूरा पहनना, entry नहीं होगी.
So how frequently do you change this sticky mats? Every 7 days?
We change it. No, it's very not so very costly. सस्ता चीज है. Change it every day. इसमें layers होता है. It's a layer.
Yes.
You just remove one layer. But I should congratulate you. I have never seen this topic be discussed anywhere.
Thank you, sir.
So
we have not thought of that. We are going to discuss to such an extent. Right. So just move on. Right. So I'll move on to environmental, as we were discussing about the standard precaution of the patient in the hospital, in the ICU. So how do we do this environmental control or patient placement in the hospital? Dr. Amit.
No, again, that like written is there is certain space between the distance between the two beds.
Absolutely.
Or maybe what I would like this physical separation is better than the what we use curtains. My opinion, because again, then changing the curtains become dirty on daily basis, then washing them. So I personally, I like that there should be physical separation between our cabins, between the two beds. So that will prevent the chance of preventing infection is more. And the logistically it is more easier compared to if you take the curtains or some other methods, that is more tedious if you take the washing and everything other things. Also, like again, that mopping schedule. There should be proper mopping schedule. It should be followed in at least in critical areas. Also, what type of chemical we are using for like high level disinfectant, like in critical areas, we should use high level disinfectants. So what type of chemical we are using, it should be certified by infection control team, and then it should be proven. So that is, there should be proper protocols. How much, because most of our housekeeping staff is illiterate. They don't know which chemical should be used and how much concentration should be used. And so we should teach them, supervise them on daily basis, whether it is a nursing team or whether it is infection control team, which are taking round, and the doctors, everybody has to be involved in that, because there is also the issue is the frequent change of the housekeeping staff on daily basis, because they are on the contract basis or something like that. So that is the most challenging part. Also the cleaning of the surrounding parts or high touch surface areas in the critical areas, which we generally ignore. We don't give it much importance to that. So I would like to highlight, like, when we talk about the ICUs, there are always three types of bacteria, either Acinetobacter, Pseudomonas, or Klebsiella. Always they complain that three bacteria are coming, most of the MDR or PDR.
Yes.
So, for example, like in my last unit, there was a mild outbreak type of thing, Acinetobacter was there. And 10 patients came, and their antibiotic profile was more or less similar. So we took the samples from various places, from jar and all these things. So from suction jar, there comes the same organism was isolated.
Right.
So then again, so we asked the team to vacate the ICU, we shifted the ICU to another CCU, and then we do the deep cleaning and all this proper cleaning, and then again we shifted so that that cycle was broken, and then there was no ICU inspector for about 3-4 months. Well, it was not like in flush plus or something like that. So there is the importance of environmental cleaning or the medical equipment cleaning. Everything is important in critical areas especially. And we ignore that part, and there is not much importance is given to that part, especially their follow-up, whether they are cleaned or not cleaned. We leave it to the housekeeping staff, and which are not in, because they are not very, they are
Agree.
the
Agree, sir. Agree.
There's a particular protocol on patient surrounding cleaning.
Absolutely.
That we should use some disposables, and it has to be cleaned from top down. So giving this kind of a training to one GDA who is assigned to the entire ICU, I mean, is asking something too big from a person who is not so educated.
I strongly
But
agree
this
with
is
you, sir.
very important.
Yep.
And collection of urine from the urobags. Two very important sources of spreading.
Right, sir. Right, sir. So this is what we have seen in almost every ICU scenario, which or we have seen that urine bag, starts spilling. So when they're draining the urine bag, the urine spills, and they do not clean it then and there. And as you rightly mentioned, when we talk about our educating a GDA, so we have to not only educate, but we have to reinforce, and then we have to check whether that is being done regularly or not. Right. So we're coming back to the transmission-based precautions, sir. So what are those transmission-based precautions, and what are the areas where this transmission-based precaution should be taken? Rajesh, sir.
Airborne, we have been seeing, and contact precautions involves all these standard precautions, right? And
Right, sir.
cleaning. Yeah.
Like whenever we talk about infection prevention and control, there are two measures. One is standard precautions, another is transmission-based precautions. Standard precaution, as the Dr. Amit has explained, it is applicable to all the patients who are getting admitted in the hospitals, irrespective of whether they are infective or they are non-infective. The second part is transmission-based precaution. Transmission-based precaution is applied only to patients who are either confirmed infective or there are suspicions of infection.
Right.
So on that basis, we take the action. So now they can be divided into broadly three categories: contact-based, droplet-based, and airborne-based.
Okay.
Now, if we come to the contact-based precautions, like we are talking today about the sepsis. And sepsis, the most common challenging what we're talking about, MDRO, whether it is MRSA, whether it is CRE, they are transmitted by contact, through contact from healthcare workers to patient, or patient to patient, or patient to health. So in that, contact precaution is very important. The most important part of the contact precaution is hand hygiene.
Absolutely.
Then again, the hand hygiene plus wearing of PP kit, what we talk about, gowns, gloves, and also that it does not but inherently you're touching your shirt and all this, so it doesn't come to your uniforms. Also, if we can do isolation, that's better. Other we can do cohorting. If there are 3-4 patients who are MDROs, so we can put them in one part of the ICU so that it doesn't spread to other patients. It should not be like one in MDRO, then one is normal patient. So in between, there will be chance of transmission is more. So that in sepsis cases, MDRO is the case, and then we have to contact precaution. Now we come to a droplet precaution. A droplet precaution is where there is a close contact. As I was telling, the close contact with the patient, because it's a droplet. When the size of droplets is more than 5 micron, so it does not travel in the long distance. It travels so short distance, then it settles down in the nearby patient surrounding.
Right.
So that, like in COVID, we tell the 12 feet or 6 feet distance maintaining, it's for that purpose.
Yeah.
So droplet nuclei does not travel for long distance. So it is only possible when you're coming to close contact, like upper respiratory tract infection, we're talking flu and all these things, it spreads by the droplet precautions.
Agree.
So then we should avoid close contact until it is very necessary, or we should wear the mask, appropriate mask. Then comes the airborne precaution. In this, the airborne particles are very small, less than 5 micron, and they can travel to very long distance. So there is no role of distance maintaining. So like in TB, in India, most common is TB or chickenpox cases. So in that, type of mask is very important, because the normal surgical mask will not prevent the infection from less than 5 micron bacteria. So in that, N95 mask is mandatory to wear in this airborne infection.
Right, sir. Please say, sir, why you? So we have to look for the contact droplet and the airborne precaution, and then we have to take necessary measure for prevention of all these measures so that we can protect us and then protect our patients as well. Having said that, I mean, in the interest of time, because this is a vast topic, we cannot go on and discussing. So it's been, we are just coming to the last part of our, this panel discussion. So when we talk about IPC program, a well-organized IPC program is a basic requirement of every healthcare facility to assist the healthcare workers to deliver quality healthcare. So this is what the WHO also mentions. These are the core component of the IPC. But to run an infection prevention and control program, we require an organized team of certain responsible healthcare personnel in the hospital. So that is known as Hospital Infection Control Committee. So that is what we are going to discuss in next 5 minutes. So what is the HICC? What is the structure and what's the role? Dr. Neha, please.
So hospital infection control committees is recognized nowadays in every hospital. A good educate hospital has this committee. It has various components. It has clinicians. It has a management person. It has operation persons. It has infection control officer, nurses, and obviously pharmacy. We have CSSD, high risk areas, all in charges we include in this. So this is actually a basic teamwork. NABH has defined high-risk zones, so it basically caters to these areas. It is definitely also a forum to cater to anything which is felt by all, but never been discussed. And I know there are a lot of problems, but I think when we sit, some logistic solutions definitely come up. And infection prevention is actually a responsibility of everyone. It is not a one-person ICU or ICN responsibility. It is a collective responsibility. ICU and ICN can just emphasize, like seeing me if somebody wash hands, it is okay, it is very good. But I think it is a personal responsibility that we clinicians also have to set very good example. So I think rather than monitoring people, setting good example is very important.
Right.
And what we do, our juniors definitely follow that.
Right, thank you. So when we talked about a bird ICN, so infection control nurse. So ma'am, Shinu ma'am, is it that ICN which is who's different than a staff nurse or floor nurse or ward nurse? So what exactly is the difference, if at all that is a difference?
The infection control nurse, we identify who has the capability to take care of the entire hospital, as she acts as a pillar of the hospital, because the infection prevention and control is totally her core responsibility. So whether tracking of patients with positive cultures, or looking at the surveillance of the hospital, or looking at the compliance of the hand hygiene, or tracking the staffs who are following the needle stick injury protocols, all those things. And also the helping the doctors and the nurses to understand the importance of following all these infection control and prevention practices is her responsibility. So the cost of the patient may increase if we have hospital-acquired infections or the staff getting needle stick injuries. So controlling that cost is her responsibility. So she has got a huge role to play, and everybody, as Dr. Neha said, it's everybody's responsibility, but that has to come from within. That yes, this is my hospital, this is my patient, and I have to control it. So everybody is an infection control nurse, but this specific infection control nurse has a huge responsibility to take care.
Right. Aptly said. So every nurse, every person in the hospital has got a huge responsibility of infection prevention and control, apart from delivering the healthcare or services to the patient. But this ICN who has been, appointed or, chosen, has got a special responsibility wherein she can be held responsible, like a HICC committee chairperson can be. So these are the roles and responsibilities conveyed by Dr. Neha as well. So of course, I just cannot, this is a vast topic as I've just mentioned. So we cannot discuss about the, HIC bundles, HIC commit, HIC responsibility, all the responsibility or all the kind of, bundles or the biomedical waste management. So, but yes, so that is also to be taken into account. So to summarize this infection prevention and control, so effective infection prevention and control is central to providing high quality healthcare for patient and a safe working environment for those who work in healthcare setting. And it is important to minimize the risk of spread of infection to patient and staff in hospital by implementing robust infection prevention control practices and program. Thank you. Jai Shri Ram. Any questions for comment. Vaishnav sir.
Every 2-3 hours, we announce this.
Right, sir.
For the public.
Right, sir.
Please hand wash and stay healthy. And I think that is important.
Right, sir.
Now we have started using this, wear mask, wash hand, stay healthy in English and Hindi both.
Right, sir.
So we should, I think in public also we should, government should, not government, all surroundings, placard and they are advertising their advertise can prevent infection by just washing your hand. Cup etiquette is another thing. I've taken that photograph and that is very important for a school. My wife is a teacher here. I'll tell her to.
Right, sir.
This is a very excellent idea.
Thank you, sir. Thank you, sir. Thank you. Thank you, panelists. Thanks a lot.
So, thank you so much. And the take-home message is that infection control is everybody's responsibility, as truly discussed here. So, to facilitate our panelists, I would like to call upon Dr. Vaishnav sir on the stage, please. And to facilitate Dr. Amit Agarwal, he's a senior consultant and head microbiology, Yatharth Super Specialty Hospital, Noida Extension. We welcome you, sir, please. A huge round of applause, everyone, for Dr. Amit Agarwal and Dr. G.C. Vaishnav, sir. Next, I would like to call. Thank you so much, sir. Thank you. To felicitate Dr. Rajesh Gupta, I would like to call Dr. Ranajit Chatterjee, sir, on the stage, please. A huge round of applause for Dr. Rajesh Gupta, sir, and Dr. Ranjit Chatterjee, sir. So, to facilitate Dr. Neha Jain, I would like to call Dr. Ashutosh Bhardwaj on the stage, please. A huge round of applause for Dr. Neha Jain and Dr. Ashutosh, everyone. Dr. Ashutosh, she is the director and head CCM, Dharamshila Narayana Hospital. And Dr. Neha Jain, she is a consultant and head microbiology, Yatharth Hospital, Noida. To facilitate Dr. Ms. Sheenu Varghese, I would like to call Dr. Rajat Agarwal. He's the director and head CCM, Fortis Escorts Hospital, New Delhi. And Ms. Sheenu Varghese, she's the chief nursing officer here at the Yatharth Hospital, Noida Extension. A huge round of applause, everyone. Thank you very, very much for joining us today, for taking out time from your busy schedules. Now, let's gear up for another energy-filled panel discussion on AMS, that is antimicrobial stewardship. For that, I would like to call Dr. Saurabh Taneja. He's a senior consultant, CCM's Gangaram Hospital, New Delhi, to moderate the session. We welcome you, sir. A huge round of applause for Dr. Saurabh Taneja on the stage, please.
Hello, everyone, and thank you, Yatharth Hospital, and thank you, Dr. Amit Goel, for calling me here. I would like to invite my panelists. My first panelist, Dr. Ranjit Chatterjee. He is Head Critical Care Medicine, Swami Dayanand Hospital, Delhi. He has maybe 100 publications in national and international journals. He is a walking Bible in RRT, ECCO2R, ARDS, critical ultrasonography, and sepsis. And I have learned a lot from him. Welcome, sir. My second panelist is a very dear friend and senior, Dr. Ashutosh Bhardwaj. He is the Director, Head and Critical Care Medicine at Dharamshila Narayana Hospital, New Delhi. Again, a very learned man with huge number of publications. He is currently the secretary of ICCM Delhi NCR branch. A round of applause for sir. The next panel is Dr. Shailendra Goyal. He is the director internal medicine, respiratory and critical care from JP Hospital, Noida. He's not there. He's coming. Okay. And Dr. Rajat Agarwal. So I learned from him since my MD days. He was senior resident and he taught me anesthesia and now critical care. He is director and head critical care medicine, Fortis Scott Hospital. Sopla. So the topic for today is antimicrobial stewardship. So we'll be talking about antimicrobial stewardship and we'll be talking about antibiotics, how we can use them. And since we know now that we are using and misusing antibiotics, and we know what are the newer antibiotics, the pipeline is very thin. So the onus is on us, how we can use antimicrobials in a very proper manner and save the antibiotics. So these are the development of antibiotics. We had a great time of development of antibiotics in between 1950s and 80s. But since 2000, the number of antibiotics that have been developed is coming down. The resistance patterns are increasing. We have to learn new and new classifications like Ambler 1. Luckily, when we were studying MD, we didn't have that classification to be asked in the Viva. But now that is a reality. We have to answer to each and every patient, to each and every colleague, what is the resistance patterns, how we choose antibiotics. And it's becoming tougher and tougher nowadays because of firstly, the resistant bacteria and secondly, the lack of antibiotics. And it is very widely said that what do you do when you're faced with an infection with a very sick patient with all resistant bugs? I think Dr. Prashant showed us a wonderful report in which it was a major booming health crisis. It was predicted long back in 2008, and now it has actually become a reality. So why do we need an antibiotic policy? So even administration of one course of antibiotic will alter the patient's intestinal flora for almost 1 year. And it takes 10 hours for a single mutant bacteria. And this study was done in Staphylococcus to grow into a colony of more than 10 million, 1 million. So they are very quick to grow. It is a real struggle for us. And mutation selection starts as early as 16 hours. With prolonged usage, it becomes more and more difficult. And sometimes in the same admission, we can have MDR pathogens in the same patient. And millions of the patients die every year due to MDR bacteria. So my first question to Dr. Ajit Chatterjee is, what is inappropriate antibiotic usage, sir?
Thank you, Saurav, and thank you, Dr. Amit, for giving me a chance to interact with you. We are more or less at the end of this session, so you must be feeling most of you are not in a mood to listen to, and it happens sometimes, isn't it? So let us be more philosophical out here, you know. You showed that first one, no? Saurabh? The first slide. The first slide. Now see the chronology of antibiotic from 1900 to 2010. My father was born in 1936. The first antibiotic was used to arrive that time. He just passed away last year on colistin. Subhash Chandra Bose had tuberculosis, 1926. No anti-tubercular drugs. He went to Dalhousie. He used to, with a frail body, used to go to a Bauli known as Subhash Bauli. Those who have gone to Dalhousie have seen, he was drinking water from there, and that was having some sulfur. That sulfur cured him because no antibiotics. Gandhiji was operated in 1924 in Pune. Lights went off when he was being operated on for appendicitis. No antibiotics. Rabindranath Tagore was operated in 1938 in his own house by V.C. Roy for his bladder cancer. No antibiotics. Today, we, the creator, is the destroyer of the whole human race. You're going to be the destroyer. We have already created such mess, such misuse, that inappropriateness starts not only in the hospital, but it starts from the shops from where we are buying antibiotics. So inappropriate antibiotics starts from there. मेरा खांसी हुआ है, कुछ दवाई दे दो, ये ले ले भाई, ऑगमेंटिन, दिन में 3 बार 5 दिन, वही inappropriateness शुरू हुआ उधर से. So the inappropriateness starts not by the doctors, but by everybody who are misusing it. So we give wrong dose, number one. We give antibiotics wrongly where it should not be given. We give antibiotics, we don't know when to start when the patient especially comes in the critical care. Before starting antibiotics, we forget to take the cultures. It is a common phenomenon. You see at 2 o'clock in the night, the patient comes to you. How many of you keep a hand in your heart and tell me that you take blood culture, urine culture, sputum culture, you tell to your residents, but how many residents comply to it? We don't take. By the time the cultures reports come, 3-4 doses of antibiotics are already gone and your culture is negative. We don't know if you are at all giving antibiotics. Still in many places, aminoglycosides are given in double doses, maybe triple. They don't know that you have to give in a single dose. They don't know what worst dose to give in. Even if they are giving, they are ending. They don't know when to end. Tell me one patient in your hospital who is staying for 1 month and not having an antibiotic for a single day. Not a single period of everybody. ठीक है, कोई बात नहीं. काम चल रहा था, कोई नहीं. अभी हम let us go to amoxicillin clavulanic acid, ऑगमेंटिन. चलो वार्ड में चले गया और कुछ दे दे. अब ओरल दे दे. करते करते जब डिस्चार्ज हुआ तब 7 days और भी 7 दिन का एंटीबायोटिक के साथ डिस्चार्ज हुआ. ये तो हाल है. और हमें मालूम ही नहीं है कब क्या यूज करना है कहाँ. फॉर एग्जाम्पल, even the laboratories are at a mistake. For example, the microbiologist sitting here. If the laboratory gives us, because we clinicians are zero, you know, my wife is also a microbiologist. You must be knowing her. So she is director professor in UCMS. She teaches me microbiology. We don't know anything about that. Streptococcus, Maltophilia. Now, your laboratory is giving positive sensitivity to piperacillin tazobactam, to beta-lactams, to aminoglycosides, to beta-lactams. Tricarcillin, clavulanic acid, it is not sensitive to anything. They're inherently resistant. Inherently resistant. Meropenem never acts against MRSA. We don't know. So these are the problems that is there. Even if in MRSA, suppose your MRSA, your laboratory starts giving from sputum, it is giving a sensitivity to daptomycin, teicoplanin, lizolid, and linezolid, and vancomycin. Should they give daptomycin? They should not. But they are giving daptomycin. As a clinician, I am zero. I've forgotten. Daptomycin de dete. Achha. Look, it doesn't work because it is infected by the surfactants. So it starts from the laboratory, maybe not your laboratory. I'm telling many inexperienced laboratories. It starts from your shops. It comes to the ICU. We don't know how to give them properly dose. We went on continuously giving these antibiotics. Ultimately, we'll end up in those which Dr. Akhil discussed, those serious antibiotics are going to come. They'll also become resistant in a few days. So this is what inappropriate antibiotic is. In short, maybe I'm a bit philosophical. I'm sorry for that.
Thank you, Dr. Chatterjee. Now we know why you know so much of microbiology. So inappropriate antibiotic usage means wrong antibiotic took for the ailment. Sometimes of antibiotics when it's not indicated, wrong dosage, wrong duration, irrational combinations. So all of these are included in inappropriate antibiotic. So my next, what is stewardship? So steward in English means an office duties or obligation of a steward. Important lines to remember is careful and responsible management of something. He has to be very careful and responsible while managing, and he's entrusted care. He has to take care. So what is the antibiotic stewardship? Dr. Shailendra could not be here. So it's a coordinated intervention designed to improve and measure the appropriate use of antibiotics. And here antibiotic terms encompasses antibacterial, antifungals, antivirals, and agents by promoting the selection of optimal antibiotic drug regimen, including dosing, duration of administration. But a broad definition is optimizing the use of antibiotics. Is critical to effectively infections, protect patients from harms due to unnecessary antibiotic use. And although not in these terms, there has been unnecessary antibiotic use in animals, which is affecting the antibiotic stewardship all over the world. So globally, this is a problem, and you have to combat antibiotic resistance. would minimize treatment failures, adverse effects, antibiotic hospital cost, and length of stay of the patients, and maybe in effect change the morbidity and mortality. So my next question is to Dr. Rajat Agarwal. Can antibiotic stewardship be done alone, or do we need a team?
So I think that's a very pertinent question, and it is related to the previous panel discussion we had about the infection control. So obviously, it's always a teamwork in medicine, and one person cannot say individually that he's the boss or he can do everything on his own. So yes, as for regarding antimicrobial stewardship, yes, there should be a teamwork, which is important, and the clinician, a microbiologist, clinical pharmacologist, somebody from the management, infection control officer, chief of nursing. All these are the various components who are there, who together run a successful AMS program in any hospital.
Thank you, Dr. Rajat. Yes, as he rightly said, it's been shown with different graphics. Actually, it leads the leadership from the hospital leadership as well as the ID specialist of critical care medicine. Pharmacy, microbiologists, nurses, clinicians, department heads, they all have to be a part of it. My next question is Dr. Ashutosh Bhardwaj. What are the components of antibiotic stewardship?
At the outset, my congratulations to Dr. Amit Goel for organizing the very first CME in critical care in Yatharth. Kudos to you. Dr. Saurabh for making me part of this panel. I would like to start with a few of my thoughts about stewardship. What is stewardship? Stewardship is to take care of something. It is to take the ownership of something. So from there, this stewardship word has originated. Now, with respect to antimicrobials, the objective of antimicrobial stewardship, this is for my friends who are sitting there, mostly from the nursing background, that they should know it in simple terms, that prescription of antibiotic, if we talk of the antibiotics, in a correct dose, correct choice of the drug, correct route, correct duration, so that you treat the patient. Your objective is to have optimum effect with less side effects and very less antimicrobial resistance, and to reduce the cost also. So everything which we are doing to attain these things comes under stewardship. Now there are, theoretical components, a lot of theoretical components of stewardship, which starts from making a very important, multidisciplinary team. A single person cannot manage the whole conundrum of antibiotics in the hospital. You have to have a team which must include a very senior person from the management for, the obvious reasons of, involvement of finances. Then very senior clinician can be the chairperson, microbiologist, intensivists, people from housekeeping, pharmacy, all those are very important. Then the second component would be to have the accountability and responsibilities fixed in the team. Then we have other components also, which I think Dr. Saurabh will be able to throw light more on that.
So we'll be discussing them in the next few slides. So these are the components. So although we mostly focus on the 4Ds, the right drug, the dose, the dosing interval, and the duration. But a very important components are prospective audit and intervention and feedback. So what exactly are we doing? Are we doing it correctly? So we have to audit everything prospectively, all the antibiotics that we are prescribing. So it uses the AMS staff trained to preview antibiotic orders and give recommendations optimizing its use. And second is pre-authorization of formulary restriction. So we have to have a set of antibiotics that are restricted to be used and approval. So like we were talking about the international molecule which we are using, cephalosporin, it's coming as Fetroza, which is maybe 1 lakh for 10, 4 lakh for 10 vials. So we have to have approval. So once it comes in India also, we have to be very careful whether we have to use it